Okay, good morning or good afternoon, everyone. Welcome to, are you guys getting feedback? Or just me? Let me just do this. Yeah, no, I think you can hear me. There's like feedback coming. I'm just trying to fix it. It's here out of the corner of my eye. Okay, I'm Dr. Brooks, Nathaniel Brooks. I'm one of the neurosurgeons here at the University of Wisconsin-Madison. I'd like to welcome you all to the roughly 15th year of this symposium. I actually started this when I was a resident years ago, and started out mostly as a lab with didactic lectures. The didactic lectures are still done with the residents on Fridays, but every year we have an additional lab and symposium to go over spine topics, and I think that this is really valuable. It gives us all an opportunity to spend a little time this afternoon together and think about different types of spine pathologies and problems and ways to treat them, ways to diagnose them, and I think this is going to be really quite educational, and it always has been for me. One of the key things I want you to keep in mind is that you really want to be interactive in these types of environments. The more you ask questions, the more we can think about it, the more you can think about it, the more you're going to learn. So please feel free. That the goal here is to talk more than listen. We have a huge group of presenters, and I'd like to thank everybody up front, and I'll thank you again at the end for coming, taking your time off this afternoon, taking time off from clinic or surgeries to come and talk and give everybody your insights. I think that's going to be really valuable for all of us. As you can see, we have more than just surgeons here. We have a whole many members of the team. Let's put it that way. And the more I've done this, the more I've realized that you really can't just think about patients simply as surgical conditions, but you have to think about them holistically, and that happens both diagnostically and therapeutically. So I think that's another thing I want you to take home from this, is to really think about all the different ways you can treat patients, and even as importantly, all the different ways you can not treat them and give them a good outcome. So the agenda today, we're going to start out with really what is a case-based symposium with some didactics, and we have a number of different speakers that are going to give us their insights and a little bit of introduction to the types of problems that we have that we're going to be discussing, and then a guest lecture from Dr. Leonard, who, although he's not stating outright that he's going to retire, I don't know if he'll live forever. So I asked him to give a lecture about everything he's ever learned in his practice and tell us in 40 minutes. So we'll see how that happens. And then the last part is talking about complications, and I think we learn as much from our complications as we learn unfortunately from our successes, and so I think that's important, an important opportunity for all of us. So without further ado, we'll start out with our first agenda item. Which is going to be, excuse me for a second here. We're going to be talking about axial low back pain, and we're going to start out with Scott Taufener. He's a physical therapist who treats spine problems, and has offered to give us some time talking to us about the non-surgical physical therapy treatments for back pain, which I think are kind of a little bit sometimes of a black box for us. I think that we often send patients off for therapy and have no idea what exactly we're doing with that patient. So it'd be good to learn a little bit more. So thank you very much, Scott. Let me get you a microphone and get you going.
Okay, yeah, so like Dr. Brooks said, thank you for having me. I'm a physical therapist at UW. I predominantly see spine, and sometimes I get a little bit offended when people say, you just treat spine. So everybody's shoulders are attached to their spine, and so are their hips, and so are their knees and their feet, and their head is certainly part of their spine. So really with physical therapy, I just wanted to go over a little bit of an intro, like what do we do? What do we look for? So when you guys either send your patients to us, or I see patients direct access without a referral, or I see them from a general practitioner or whoever it may be that's sending them to me, I want to make sure that they're appropriate to treat, or do I have to treat and send them somewhere, or do I just need to send them off? Most of the time, it's treat. Some of the times, it's refer. And if it's a referral, I like the old school method of referral and a face-to-face, please see this person for me. So if I see you guys in clinic or you see me come up, I probably have a patient that I've examined and I think they need your care. Other part of physical therapy is really establishing the patient's expectations along with letting the patient know what the physical therapist's expectations are. So patients who don't want to be in physical therapy don't generally get better. And I can't help them necessarily get better if I can't convince them to be there. So just setting up that patient physical therapist relationship and role, what am I here for? And also letting them know that, hey, I know some other people, if I can't help you get better, that can help take over care if needed. Kind of this black box, what do you do with what do physical therapists do and what do we treat? Well, 85 to 90% of low back pain is nonspecific, which means about 10% of the cases, 15% maybe, involve some sort of direct identifiable problem that someone can treat with maybe surgery. So that means the majority of people I see don't have a specific problem. And this is the physical therapy world, the low back pain, where we say you have low back pain and it's radiating, or you've got some stiffness or mobility problems, or maybe you have too much mobility and you can't control it. And then our treatments kind of all focus around that. So what I'm looking for is more of an impairment level problem with the patient, meaning are they weak, loss of motion, hypomobile, they just don't know how to move, they're poor movers. Do they have radiating pain, radiculopathy, or are there mental health issues contributing to their symptoms? And then oftentimes what we're really looking for is what is maybe causing stress into the area where they're having their pain. So I'm a big believer in where we hurt isn't always the problem, right? So maybe these lower lumbar spine problems are actually a thoracic problem causing stress into the back. Maybe these lower lumbar spine problems are actually a bad hip or a bad knee. And a bad hip and a back, those are tough ones to figure out, and that's a little bit hard. But sometimes people with history of ankle injuries or knee injuries certainly come in with back pain, and their back does have a mechanical problem and sometimes an identifiable problem on imaging, but we still can't just treat that spot directly. So treating the whole person really is what we're looking for in physical therapy. Regional interdependence is what we would call that in physical therapy world. Have you guys heard that term at all, regional interdependence? Right, so a good example of that is, say you can't turn your head, but you have to back up your car. How are you doing that? Now you're all in swivel chairs, I think, right? But if you can't turn your head and you have to back up your car, you're gonna just turn something else. You're gonna turn your whole spine. Where is that person gonna hurt? Their low back. On a rare occasion, that person doesn't identify they have a neck problem and they have low back pain that comes up. Now I see them, their low back exam looks normal, neurologic exam looks normal, but it hurts. Well, I gotta treat their neck. That would be regional interdependence, right? So what do we do in physical therapy? I manipulate, crack backs. I don't adjust. Chiropractors adjust. They own that term. I don't tell patients I adjust them, right? Because I don't believe in that theory of intervention, but I do manipulate. Some of our DOs are manipulating, and actually in the system, a lot more DOs are manipulating. But really what I'm looking for is, can I change your pain or mobility and trying to get the patient to buy in. So as a physical therapist, I need you to come back. I can't see you once and have you be fixed. I've had that happen once or twice, and those are lucky. But I need you to come back. So I need to get buy-in. So we can use manual therapy as a buy-in, but it's never a standalone treatment. Exercise. What is the best thing for any person with back pain or any musculoskeletal health problem? Exercise. What exercise do we do? I don't know. It depends on the patient, it depends on their impairment, it depends on their level of ability to start physical therapy. Classically, a lot of patients start physical therapy, or at least the thought is that you would start physical therapy for spine-related problems laying on a table, telling them not to move their back, and then hopefully they can stabilize their spine and do some exercise. The percentage of my patients that I start laying on their back, doing stuff, telling them not to move their back and be real still is really low. To me, there's also a little bit of a negative implication in that, is that I'm telling them to lay on their back, be real still, and don't move your back. So that's not really the best advice for most patients. They're safe to move, and I treat them, again, at the level that I can meet them at. Other barriers that I have to think about for treating the patients is, how are we going to do exercises at home? So time commitment of exercise is a big one. space, my patients generally need 15 minutes, 10 feet, and a rubber band. And that's if they're coming in for neck, shoulder, mid-back, low back, hip problems. I don't see many knees and ankles individually. Also educating on hurt versus harm. We get a pain signal, we think it's harm, we don't do it twice, right? So educating patients that if you do something today and you're not worse tomorrow, what you did today is just fine. But getting them to realize that and experience it themselves is where the learning process really takes a hold for the patient. So you got to show the patient they can move, and then they have to find out they can move on their own. And then they know they're causing hurt from exercise maybe, but not harm. Harm is going to be more of a building sort of a problem. So week to week, also my patients shouldn't be getting worse. Some fun modalities that don't have a lot of evidence, but sometimes you hit a home run with, dry needling. How many of you have heard of dry needling? Yeah, so it's really all the rage for the new stuff. So I scoured a lit search, what's new and fun in PT and has good evidence? Exercise. It's the same as it's always been, but we're doing dry needling. I've had patients that don't get better with other stuff and we do dry needling and they get better. I've had other patients we dry needle and they say it feels good, but it doesn't change their pain or mobility or ability to complete their daily tasks. I can't predict it yet, but if you're willing to pay an extra $115 and we've tried everything else, I'll go ahead and give it a whirl. Traction, not really supported, but again, there are some patients that benefit from lumbar traction. Cervical traction is a little better supported in the evidence, but really not lumbar traction. It's more of a pain modulating modality rather than it is fixing somebody's disc herniation. E-stim, really low evidence, but again, if you've run out of other options and it helps gate their pain, go ahead and try E-stim. And again, sometimes you use these things to start care, to get buy-in to exercise, improves pain mobility, and then you move on from there. All right, so over the course of care, what am I looking for? I want to see what happens. And I have an open discussion with the patient. Over the course of physical therapy, I want to see you move better. I want to see your pain go down, or I want to see your activity go up and your pain not go up with it. If you can do activities and your pain doesn't get worse, that should show you we're not causing harm. Pain is probably the least thing that I try to focus on through therapy. We focus on function, range of motion, strength, and again, getting the patient back to function is what we're really looking for. Ways to get patient buy-in between visit changes. So I can help, I would bet I can help 97% of patients move better at the eval. But I want to see them maintain that on their own with the exercises I give them. And once they can move better, free up their spinal segments, whatever it may be, then usually you can tolerate exercise better, pain goes down, and function activity go up. And then the end goal of physical therapy is self-management, so that the patient can continue to do these things, keep their joints healthy, reduce stress into their body, and not see me again, and hopefully not see you guys. But my expectation is that they're going to have a positive change in 6 weeks. If they don't have a positive change in 6 weeks, and maybe I'm seeing neurologic weakness, or we've got imaging findings already of something like a spondylolysis, spondylolisthesis, maybe disc herniations, or again, I'm seeing signs of a radiculopathy that's getting worse, I'm going to come to you guys for help. And I won't wait 6 weeks if I'm seeing progressive pain and symptoms. But again, the total course of care for therapy, I see patients from weeks to months or years, hopefully not years, but sometimes it's years, and usually those are recurrences, and they're not surgical candidates for many reasons. Some of them are, they just don't want surgery, and then I try and talk them into, it's not that bad all the time. But again, the biggest thing is to shift the patient focus to function over pain. So getting your patients moving, having them be able to be active without limitation despite pain is really the goal of physical therapy. And when none of that works, send them off to you guys. And again, I like face-to-face handoffs for these things or additional treatments. So you may see me come and ask you questions. Anything with that?
Perfect. Thank you very much.
Thanks. Yeah, I threw a couple articles that are just kind of general articles. But
We also have questions for Scott, although we're going to have a little bit of a panel discussion. Any particular comments. I think one of the things I want to just bring up and let you know is that I'm often trying to explain to patients that we haven't found anything dangerous going on, and that the pain they're having often does need to be worked through, like a Tin Man syndrome kind of thing. And
yeah,
so
exactly.
if they can start to kind of work through the discomfort and knowing from our end that there's nothing dangerous or surgical, then that sometimes.
And that reassurance from your end really goes a long way to the patient. Yeah, they believe most of what we tell them, but they believe what physicians, surgeons, and PAs tell them, sometimes a little bit more. But I can be a pretty good salesman at times too.
Perfect. Thank you very much. Appreciate it.
And say they half the time believe what I say.
Yeah. So I don't know why that is, but it is to some degree true. There's often a desire for a surgeon's opinion, even if everybody else has told them that you don't need a surgeon. So as you can see, we're kind of escalating up now. So we've moved from physical therapy, which is going to be, of course, managing the bulk of the low back pain patients with no radiating symptoms, no weakness. And then now we're going to move into the rehabilitation / interventional pain pathway, and learn a little bit more from Dr. Sewer, who I've worked with for years. Is a great guy. And we've actually done courses like this or a symposium like this at national meetings at NASS, where we talk about much more complex hypermobility patients and things like that. But I think this is a really good way for everybody to learn about kind of what the treatment pathways look like, and then eventually get to surgery. So thanks, Mike, for your.
Yeah. And I do got to tell you, Than, I don't like you putting ideas in Jim Leonard's head about retiring. He and I are going to retire at the same time because I still have a lot yet to learn.
He never said anything about it.
Yeah, don't put those ideas in his head. All right, so low back pain, everyone's favorite topic. Easiest thing to do, nothing ridiculous, just punt it over to PM&R here. Real simple, easy consult. But they will oftentimes ask, what kind of things are you going to be doing? And for the surgeons in the room, if you see a patient that we've seen before and you want to know, well, why in the world did we do X, Y, or Z? Hopefully shed a little bit of light of why we did what we did. To break it all down, I knew Seth and Than were going to be here, so I decided to do a flow diagram because I haven't seen enough of these doing specialty care redesign. But this is how I tend to think about it. You have a patient with low back pain, and I'm trying to break down essentially what type of pain is that. Is it more mechanical, neuropathic, or is it kind of this mixed, unclear, I don't really know what's going on? From there, that kind of leads you toward different diagnoses. And one of the hard things with back pain is that it is rare for an individual to come in with one single isolated issue. Kind of like what Scott was talking about earlier, it's one thing begets another, begets another. So you may have a person who originally comes in for some stenosis, but they also have arthritis, and then their muscles hurt, but then they're changing their posture, so their SI joint hurts, that throws off their hip. And so you're always trying to dig a little bit deeper to figure out, okay, why does this patient have back pain? What's their underlying issue? And that's one of the harder things to do actually in the pain world. But if we break this down, facet-mediated pain is incredibly common. Most patients who come in with facet-mediated pain tend to say they wake up in the morning really stiff, really sore. That's one of the worst times. They can get through the day. End of the day is painful. End of the week is painful. But it really is this activity-dependent type of pain. And for a lot of these folks, if you work a manual construction job, for instance, they'll say, Monday, Tuesday, I can get through it. By Thursday, Friday, my back is just killing me, and I've got to get to the weekend so then I can get through the weekend, recover, and go at it again Monday. And so a lot of times when I'm talking to patients, one of my initial questions is, well, how do you feel when you wake up in the morning? How do you feel kind of going throughout the day? Is there certain activities that really tend to flare it up? If you do too much in a day, are you going to pay for it for a couple of days afterward? And if the answer is yes to a lot of those things, I tend to think more facet-mediated or joint type pain. SI joint can do similar things, but we'll kind of get into differentiating those two here. Honestly, for clinical exam, and this is kind of a theme throughout a lot of this low back stuff, there's nothing great as far as, if I do facet loading. So if I take the patient, rotate them over and bend them backward and it hurts, does that tell me for sure this is SI joint or that it's, facet joint? No, it doesn't. Maybe it leads you a little bit toward that direction, but it's not going to be a surefire, very sensitive, very specific physical exam maneuver. Actually, when they looked at radiofrequency ablation for facet arthropathy, when they went back and looked at what physical exam findings were actually predictive of good pain relief after an RFA, it was just pressing on the muscles. So paraspinal tenderness, which is about as non-specific as you can get. Now, when we do this procedure, it's a 3-step process where the first 2 we're blocking the pain from the joint, and that's the medial branch block. The third time they come in, we do what's called a radiofrequency ablation. A lot of different ways of doing it, different companies, different technologies, but it all works essentially the same way. That you're putting in a needle at the medial branch and denervating via usually heat to stop the nerve from sending a signal. On average, people are getting 9 to 13 months of pain relief. It's all over the place. You'll have some people come back with 6 months of pain relief. I saw someone 2 weeks ago that's going on 4 years, still doing great. It is all over the place. And usually with this, one of the things we really want to push is because we're also denervating the multifidus muscle, that we want patients going to physical therapy after an RFA so that when this nerve starts sending a pain signal again, their back is better supported. Better flexibility, better strength, but getting patients motivated when they're feeling good to work on core strength, core stability, flexibility is incredibly difficult. But for me, I try every single time we're getting someone in for an RFA to say, after this, we're sending you to PT because it's going to wear off. You want your back to be in a better spot when it does. The SI joint, very, very similar. It's going to be a mechanical type pain, so this aching, stiffness, pain in the low back. A lot of different SI joint maneuvers that you can do as far as a physical exam. None of them are great. As far as the symptoms go, what patients tell you, they may still have morning stiffness. They'll a lot of times have increased pain with more strenuous activities. This one gets complicated because the SI joint can refer pain down into the leg. So it can mimic a type of radicular pain. The muscles in the low back and buttock in particular tend to tighten up when people have SI joint issues as well. So upper buttock muscles, especially the glute medius, tends to radiate pain down the leg. So we'll have patients come in and it sounds like SI joint, but they're having this pain down the leg. And then when I'm doing the SI joint provocative maneuvers, especially pressing on some of the muscles to try to find the tight spots, I'll say, okay, if I press on this muscle, is this shooting pain down your leg? And for me, that's usually pretty indicative that it's not a true radicular pain, but more coming from the muscle. As far as these SI joint maneuvers, I'm not going to go into detail on these. If you guys have done these, you know that none of them are great. I have all of them drawn up here that we commonly use. I frequently use sacral thrust, thigh thrust, Gainslin's, Faber. I don't have on here, but I use that one a lot. But when you break these all down, looking at the sensitivity, specificity, likelihood ratios of all of these, none of them are very good. However, when you combine them and you have 3 positive SI joint maneuvers, then you're starting to get into the 90% range of, all right, 3 positive maneuvers, 90%, 91% likely that it's a SI joint issue. The gold standard actually of diagnosing SI joint is injecting the joint with a local anesthetic. However, rarely are we actually doing that. We're almost always injecting a steroid. When you inject a steroid, you're going to have a global response to the steroid. But we do look at pain scores the day of an SI joint injection to try to get some diagnostic value out of it. The radiofrequency that I talked about for the facet joints, we can do that as well for the SI joint, but it flips. So for the facet joints, the joint injection is 2 to 3 months of relief. Insurances rarely cover it. Doesn't actually work great long term. The radiofrequency works really well, and insurances cover it. Flip for the SI joint. The joint injection works pretty well. The radiofrequency doesn't have a ton of research. Insurances cover the joint injection here, but not the RFA. So there is a little bit of insurance dictation on what we do as far as this, because a lot of insurances just flat out don't cover the RFA. I'm not going to get into fusing the joint. There are a lot of pain physicians who fuse the joint. Some of our orthosurgeons fuse the joint here as well, but that's kind of beyond the scope of what I was going to talk about. Just briefly touching on myofascial pain, almost all of our patients with back pain have some sort of myofascial pain. It's just a question of, is that a primary issue or a secondary issue? If patients are coming in and they have altered gait mechanics. So they got stenosis, they're leaning forward, their muscles are tightening up in the back. If you go in and do a wonderful treatment for the muscles without treating the underlying issue, it's ultimately not going to get a lot better. But this is something that a lot of times we'll address, and it looks so myofascial, and we'll say, okay, if this myofascial treatment works, wonderful. If it doesn't, we need to start digging deeper to say, why are these muscles tight? What's the underlying pathology to cause the tight muscles? But very, very common for this to refer pain down into the leg. Switching here to the neuropathic pain. I know I'm going through all this stuff quick, but time is of the essence. So stenosis, specifically no claudicatory symptoms, no radicular symptoms. This one is tough to diagnose. Oftentimes what we think about is patients who are walking and they lean forward and that relieves a lot of their pain. The caveat to that is, are they leaning forward, putting a lot of their weight like on the shopping cart and almost distracting their facet joints and giving themselves a little bit of almost like an inversion table where you're giving some traction to the joints. And so a lot of times when I'm trying to parse this out, I'm asking the same facet type questions to try to get a vibe of how much of this may be related to arthritis. But then when I ask, all right, if you walk around the grocery store, do you need a shopping cart? Like, yeah, I need a shopping cart. Okay, do you think it's just the act of leaning forward, or are you just putting a lot of weight on the cart? And usually they'll be able to differentiate those two things. But oftentimes, patients with stenosis are also going to have arthritis. So this ends up being a very, very mixed picture when you're seeing them clinically. The goals of treatment, exactly the same thing Scott talked about, as far as we're trying to decrease pain, increase walking distance, increase stamina to hopefully build up some of that endurance. And then if the other types of pain don't get better, so the facet arthritis, the SI joint dysfunction, after we treat this, then we'll circle back around to treat those secondarily. Oftentimes the epidural injections, you're going to see patients who have these. It's debatable on how exactly these work. I've thrown in some ideas on how exactly these work because we know stenosis is a compressive issue. So how does injecting a numbing medication and a steroid help with a compressive issue? Suffice to say, it's complicated. We don't understand it fully, but I think everybody in this room knows that you get some relief for some patients with these. They've done a lot of research trying to determine how effective steroid injections are. And part of the problem is that a lot of these studies are for miscellaneous conditions and they're grouping a lot of things together. And they're not necessarily parsing out the specific diagnosis, the specific injection, whether it's a midline injection versus a transforaminal. And so the research studies are a little bit mixed on this. One of the other questions as far as the injections is, do you include steroid or not? And that's a whole separate debate. One of the things, as far as if you guys are ordering injections for us, is to consider, where you would do this injection. I think it's probably getting into the second part of this. But we would all look at this and we all know exactly where the stenosis is just by looking at the picture, but there's really just not enough space there. And so you may see a patient of ours that you're like, hey, you guys had the stenosis here at 4 or 5. Why didn't you inject that? Well, why didn't you go a little bit below it, inject there? Because the medications are going to float up a little bit. Well, it's because there's no space there. Well, why didn't you go above it? That's pretty close. Inject that spot. Well, when you look at the spread of the medications, if you inject here at 3-4, and if you just consider an average of 4.5 mLs of contrast, it's going to flow up actually better than it flows down. And so you may see one of our patients and you're like, well, why did you order that injection go in essentially through the tailbone? Well, this would be why. We're trying to get the medication up into that spot. So for this patient, we're going to do an epidural injection through the tailbone, a caudal epidural, trying to float that up there. All right, last one, which is honestly the hardest one, I think, to diagnose, discogenic pain. These patients oftentimes are younger. So the classic person is someone who is a 25-year-old weightlifter who deadlifts something and their back, it goes out. And this happens 2 or 3 times a year and they come in, maybe they're actually feeling pretty good today, but they're just tired of it happening. Dr. Leonard does this a lot, the lumbar overpressure test, having them prone and extend backward and putting pressure onto their low back to see if it improves. But there's not really a specific diagnostic test. There's nothing really as far as symptoms that you're going to look at and say, I know it's discogenic low back pain. Now, you can look at the MRI, and you may see a high intensity zone like we see here at L5S1 and say that's likely potentially causing pain. You can see modic changes, potentially a cause of discogenic low back pain. But this one gets really difficult. And to that end, there have been newer procedures that are coming out, like burning the synovertebral nerve, the Intercept procedure, to try to get rid of discogenic low back pain. But even if you talk to those folks, the reps, as far as, well, how do I know it's disc causing pain? They'll say, you'll see modic changes, and nothing else works. And so it's a very, very tough diagnosis. I tend to prefer doing transforaminal epidural injections for discogenic low back pain. Looking at the lateral view, the needle is more anterior. It's closer to the disc compared to a midline injection. And typically for these, I do bilateral. And really on these, it's important to get contrast flow medial to the pedicle and up toward the disc. And if you're having a hard time getting in, the medications are flowing, lateral, and you're not getting that flow in, it's really hard to know how effective that injection would be. And that's oftentimes one I would try one more time. But we really want to see that contrast flowing medial to the pedicle, which I have there in yellow, up toward the disc. All right, so a whirlwind through pain medicine for low back pain. Sure, you guys have seen some of this stuff before, so nothing as groundbreaking as the shovel, but that's a dad joke. That's a
Nice dad joke.
Yeah.
Thank you very much.
No one laughed. Lauren, I got Lauren on that one.
Thank you very much for coming. Appreciate it. Dr. Boyd.
Thank you. Thank you. Can you hear me all right? All right, cool. Thank you. So surgical treatment of low back pain, this can be an exhausting endeavor to try and look at all the literature and give a talk that will give great clarity on what you should do, who you should operate on. It's just very difficult. And so rather than trying to do an exhaustive and exhausting overview, I'm going to try and do a little bit more of a focused overview and try and give some pearls to help with the treatment of low back pain with surgery. These are my disclosures. They are all related to spinal fusion devices. And so I think hypothetically, I do have conflicts that would be in favor of spinal fusion. So keep that in mind when listening to my recommendations.
I tell patients that I have that conflict all the time.
Yeah.
I say, it's really in my best interest to operate on you. So if I'm saying no, that's against my interest.
Right. Yeah, it's true. And I found that I think that I used to think that the number of back pain operations a spine surgeon would do was mainly directly related to the number of ex-spouses they had, the number of houses they had, and the number of boats and the number of cars. And the more of those that you check off, the greater the number of spine surgeries for low back pain you do. Spine surgery is uniquely predisposed to criminality in that regard. And so I think it's important to have good, meaningful, thoughtful indications on when you operate on somebody for low back pain. So I think there's kind of 6 entities that we talk about in terms of being potentially surgical for low back pain, and I'm going to focus on 3 of them. And that is isthmic spondylolisthesis, patients who've had a prior discectomy, and those with degenerative disc disease, like Dr. Sewer was talking about, presumed discogenic back pain. The other 3 entities that I can think about are degenerative spondylolisthesis, severe spinal stenosis with neurogenic low back pain, and scoliosis. But those are kind of different beasts. And so today we're really going to focus on these sort of single level problems: isthmic spondylolisthesis, patients who've had a prior discectomy, and those with degenerative disc disease and no prior surgery. So there's kind of 3 main, pretty legit randomized clinical trials looking at the surgical treatment of low back pain. So hundreds of people, you randomize them, you've got fusion group and a non-fusion group, and these all took place in like the early 2000s. It's just really difficult to do this kind of study, especially in this day and age where you're going to ask people to randomize to get a spinal fusion versus no fusion. You're going to have tons of crossover, and it's just very difficult. But so these were done in an era where you could kind of pull that off a little bit better. The one caveat is that these are all like conventional open surgical techniques. So midline incision, wide exposure, all that. We do things a lot differently now with A-lifts and laterals and percutaneous instrumentation and MIST lifts and all that. So these were done kind of a little bit in a different era. And so these really are the main 3 studies that were done. And then there's been a lot of follow-up studies that do meta-analyses type of assessment. And then there's also this small kind of subgroup where people looked at total disc replacement instead of fusion. And so really, when you kind of synthesize that all, I'll try and give a really oversimplified conclusion. Well, that is that there really is no clear evidence that surgical treatment, whether it's fusion or disc replacement, for low back pain is superior to non-operative management. However, some patients do benefit from surgery. And so that's the tricky part, is figuring out who is potentially going to benefit from surgery, who do you offer surgery to. One really, I think, important part of these studies is that the psychosocial factors have a great effect on the success rate. With respect to fusion or disc replacement, there really hasn't been much difference. Lumbar disc replacements have become uncommon and are only done really in a few centers. They just really have not borne out to be successful, not nearly to the same level as cervical disc replacements. So generally speaking, when we're talking about surgery for low back pain, we're talking about fusion, and that's why. So these are the main psychosocial aspects that I think should be weighed into the consideration of whether somebody should have surgery or not. Mental health, smoking, drinking, employment status, all of those. And then there are anatomic considerations. And so you're going to have a higher success rate in somebody who has a BMI of 22 than somebody who has a BMI of 50. And then the numbers of levels involved. I've done a few low back pain surgeries for 2 levels, but for the most part, the success rate really drops off pretty dramatically when you have more than 1 level. And so from an anatomic consideration, you're really trying to identify that person who has pathology really isolated to 1 level. And if you look back on these 3 MRIs, you'll see that all 3 of these have normal discs at all the other levels, but have pathology limited to a single level. So there's isthmic spondy down at 5.1. There's prior discectomy at 5.1 with all the other levels looking good. And here's degenerative disc disease with the modic changes that Dr. Sewer was speaking of. And so from an anatomic consideration, a single level is most important. So now I'm going to just give my opinion and my approach on how to treat these patients. And so I can't say that this approach has great scientific validity, but I've been in practice 16 years and I've been in practice with a lot of very well-known spine surgeons, and I think we generally have a similar approach. And so this is my approach to it, and that is that 95% of my surgeries for low back pain, I want them to be performed for either isthmic spondy or patients who've had a prior discectomy, meaning that if somebody comes in with discogenic pain and that seems to be the problem, I really don't want to operate on very many of those patients because the success rate is lower. I think part of it is that when you have someone with isthmic spondy or they've had a prior discectomy, I mean, they have a clear anatomic structural problem in their spine that we can fix. Whereas with the discogenic pain, there's just so many other factors. And so basically the more surgeries you do on patients with discogenic pain, the more failures you will have. And so if there's maybe a 50-50 success rate and you do a lot of those surgeries, you've got a lot of ex-spouses and you've got a lot of cars and such, then you have to move every couple years because you're going to have a lobby full of patients. If you have a 50-50 success rate for elective spine surgery, you're going to have a lobby full of people who are not happy with how things are going. And so from my perspective, when I see somebody with an isthmic spondy or they had a prior discectomy and they have low back pain and they look good on all those psychosocial aspects, I'm pretty likely to offer surgery to them. It's the discogenic one that I'm going to be a lot more cautious with. The second thing I do is I want to make sure that they meet all or close to all of those favorable psychosocial and anatomic criteria. So like kind of the ideal person is somebody who's maybe in their 30s or 40s. They're athletic, but they are not able to perform the type of activities they'd like to perform, but they are still able to find some way to exercise. So they still are able to find some way to exercise. They have a good support group at home, you know, maybe they're married, girlfriend, something like that. They have a job, you know, they're like an accountant. They don't smoke. They're not overweight. It's just like a totally normal person, basically, is what I'm describing. That's what you want to have, is like a totally normal person. And if you have that, then you're going to have a greater chance of success. But we aren't all normal, and some people are missing maybe a couple of those things. Maybe they're overweight, or maybe they haven't done physical therapy, or maybe they smoke. And so what I like to do is I like to give them a mission, because really you need to establish a relationship with these patients to make sure that offering them surgery is appropriate, because the outcomes are so mixed with low back pain. And so what I typically do is I give them a mission. I have them go do PT or injections, weight loss, smoking cessation, all of those things. We follow up open-ended. And if they come back to me and they have accomplished those things, then I feel like that's helped me gain confidence that that patient will have improvement after surgery. I never sign up a back pain patient for surgery at the first clinic visit, and I don't schedule follow-up. I treat that first visit, and I tell them this right off. I say, hey, look, we're not really going to talk too much about surgery today. We're going to have more of an information style session where we're going to talk about the role of surgery in the treatment of low back pain and the reason why it has such mixed success. And then at the end of this, I'll give you what I'll write down what my typical surgery would be, which is often an ALIF with perc screws. And you can research what that's about and think about things. And if you want to come back and talk to me later, we can. But I don't sign them up at that visit. I have them go away and think about it and process it. And that helps us, our group, to understand if they're reasonable or not. I document in layman's terms, and then I ask my nurse to verify with that patient that they've read the note and they respond affirmatively that they have. So that's usually via a MyChart message. And so then I know for sure that the patient has read that. And what you'll find sometimes with these patients is they might seem totally like normal to you, but then when you look at the telephone encounters later, you'll see that they've really treated your staff poorly. And to me, that's a sign of somebody that I will not offer surgery on, because I think that maybe the number one predictor of failure is an angry patient. And so you need to, you know, make sure that the way they act with you is the same with everybody else, and that they're like normal, reasonable people. I make expectations crystal clear. I say, hey, this has a really mixed track record. There is a very realistic possibility that if you have surgery for low back pain, that you will come back and you will still have the back pain. It's unusual to be worse, but there are risks of complications, and that is possible. But for the most part, the biggest problem would be that you don't get better. And if that happens and you come back to me and we get a CT scan and it's fused, there is not anything else that I'm going to be able to do for you. And you need to be comfortable with that and accepting of that possibility if you're going to have surgery. And basically all I'm doing there is, setting expectations clearly, but you got to have an exit strategy. The last thing you want to do is have one of these back pain patients sitting there and be like, now what, doc? Because there is no now what. After you do a fusion, there is no now what. And so you need to cover that in advance. And I do have some patients, we all do, who've had low back pain surgery who have not done well. And they say to me, you know, you told me this could happen. And I really want them to know that very clearly before going in, because otherwise these patients can be particularly problematic. I personally have found the pain psychology evaluation to be very helpful. I first kind of became aware of that looking at the patients who were having spinal cord stimulators performed, and they all have to get the pain psychology visits, and I found those to be very helpful. And so I require all patients, not necessarily the isthmic spondyes and the status post discectomy ones necessarily, kind of depending on if they're totally normal otherwise, but definitely the discogenic ones. And the way that I frame it is I say, hey, look, everybody who undergoes fusion for low back pain, everybody needs to go to pain psych first. That's just a requirement. I'm not being judgmental. You need to do that first. And what they're going to do is they are basically going to help identify factors in your life that are working against you and factors in your life that are working for you with respect to recovering from this surgery. And we want to try to maximize those items that are working for you, and you want to find ways to mitigate those factors that are working against you. And then I read the pain psychology eval, and I found that to be very helpful. And then finally, an opioid discussion. It's, I'm not going to do a back pain operation on somebody who's on opioids. I'm not going to do it. And I'm not going to prescribe opioids beyond a few weeks after spine surgery anyway. All patients who have spine surgery with me have a preoperative pain plan that we formulate and discuss and document and print out and give to the patient in advance. And part of that includes very specific language, and I discuss this with them also, that if they have ongoing pain and they feel like opioids are the way to go with that, and I think there's pretty good evidence to say that that's not the way to go, but I'm not going to be the person who is prescribing those opioids or doing any of that type of prescribing. So that's my take on surgery for low back pain. Thank you.
Perfect. If I could have the first three presenters sit down in the front, and you use that mic if you would. And then I'll get you 2 more mics here. We're going to go through some cases. Any comments while we're getting set up? Okay, thank you, everybody. Those were all great talks, and you can see kind of that escalating role of different types of interventions and treatment can really provide a little better insight about how we treat this types of patient. So what we're going to do now is just go through a few cases. We're a little bit behind schedule, so we might cut one of them short, but at least try and get a little bit more information about kind of resynthesizing what we've already heard. And anybody who wants to make comments, questions, that would be great. The first case we're going to start with is a 19-year-old woman with bilateral pars defects. She has had on and off back pain from the time she's about 15, 16, and was a volleyball player. And now she presents to you, she's had very much on and off symptoms, meaning maybe once a year she'll have some sort of back pain episode that gives her some discomfort, limits her activity. She finally felt like she needed to kind of get these things evaluated and presents with this MRI scan. What we'll say about this is that the MRI shows normal appearing discs, normal appearing spinal canal, no compression on the nerves, and then you can see these bilateral pars fractures at the L5S1 level, which are the main finding. So I'm going to start on the non-surgical side with Scott, and then kind of work through to surgery. But certainly we don't have to do surgery, but it's just a thought that we'll go through those things. Okay, if you would.
Yeah, so I'm assuming too there's no reactive edema. It's not.
No, and even now, like you see her now, she's basically in our clinic, she's pain-free. Basically, her primary care doc's like, what do we do?
True intermittent.
Yeah, there you go.
Yeah, so I mean, in my case, physical therapy, like I said, this is more my regional interdependence. So I'm assuming this volleyball player probably is having a poor time dissipating torques from rotation and extension. So I'm probably looking at her hips and her thoracic spine and looking at her control of the movements of her body in general, just in my room. And then either through, usually someone like this too, I'll probably manipulate their thoracic spine, right? Your whole spine is connected. So might do thoracic manipulations for this person, make sure their hips are normal mobility. If she was a swinging sport, something, I'd assume her lead hip internal rotation would be restricted. And again, I'm looking for mechanical stresses that are going to cause extension and rotation torques into her back for this posterior element issue, especially since it's on and off pain. So that's what I would do. Probably, and if you look at any of my notes, if you see my patients, everyone's doing glute med strengthening. And I don't discharge patients until they can show me good control over rotational forces. So med ball throws or some sort of upper extremity D2 pattern where I want to see how they dissipate and use and produce that force from their feet up through their arm.
So that's great. And I guess one of the comments I often make to patients when I'm sending them for therapy, I tell them, they're going to ask you to do some kind of wonky exercises, and especially for an athlete, former athlete, they're going to be like, this isn't exercise. How do you coach them through that? Because sometimes they'll be like, oh, this is just like a little thing. Like, how's this going to help me?
Yeah, so I mean, in therapy lingo, we talk about stability and then control mobility and then mobility. So an athlete, if she is moving generally well, or if she's strong in general, she's got good lumbosacral control or multifidi look like they're doing what they should. I'm personally probably starting these patients with side steps and monster walks, and I'll get them doing some single leg RDLs, maybe having them do lat pull downs. I think something people forget too, your lats are in your back. So I give them shoulder exercises for their back, but I really try and work these patients head to toe.
Yeah.
Because I think this one in particular is a problem with force dissipation. So, and I get them up and moving. The number of patients I give exercises laying down, probably 2% that I stick to laying down, and that's because they can't tolerate standing. And then eventually I get them up and standing. So, but it's a hard sell to get somebody to do stuff laying down when they're a high level athlete.
Yeah. They're like, they think that's funny. Okay, Mike, go ahead.
This microphone's working okay? Okay. So first of all, you probably would already have x-rays to make sure there's not dynamic slip.
Yeah, so the x-rays don't show any dynamic.
Okay. So that's a tough one when it's like a once a year thing, because at that juncture, I wouldn't want to do any type of injection into the pars. Now, I do have.
Now I'm going to change the story for you so that, Scott worked with her for a year or two.
I was going to change the story.
Yeah. And so now she's having it more consistent low back pain.
And that's oftentimes when they end up with us. And I do have some athletes who, high school, college athletes who have these chronic stable pars defects, and they have a hard time getting through their season. And if it's a consistent thing and they've tried all the other stuff as far as PT, massage, even doing some dry needling, things like that. And there's nothing ridiculous. A lot of times actually injecting the pars defect, locally anesthetic steroid, can give people months of relief, but you need to have a discussion on that as far as like, what's our actual goal with this thing? If you're a high school athlete, I can inject the pars defect and get you through your basketball season. But if you want to play college basketball, are we really going to be doing this every single season for the next 8 years? And have that discussion early, because once you do the injection and it works really well for 6 months, they're going to want to come back and have it done again and again and again. Mm-hmm. And so to inject a 18-year-old every 6 months for 6 years, it doesn't sit right. And we know long-term use of steroids is not good. The residents just in a journal club about that this morning. And then you're looking at other things. Are there anti-inflammatories you can use, topical medications, bracing, things like that? And so, it's simple to just jump to the injection because you can say, I think the pars defect is what's causing the pain and it's going to work. But the question is, what's your long-term goal with it? And that needs to be a discussion with, honestly, the kid and the parents. So
in this case, no longer parents involved, and we're going to say not former athlete, but active human, right? So, in those scenarios, what do you tell them about the risks of living with this, doing whatever they want to do? So with episodic pain versus
yeah. So if it's an episodic thing, I actually have a buddy that was a professional basketball player, played 8 years with the pars defect, and now he's in his 50s. And he says, as long as I swim once or twice a week and I do my core exercises, it's not that bad. 3 or 4 times per year, it'll flare up. And so that's a common example. The other thing, when you look at the research studies, a lot of people don't know they have this until they get a random scan. So the majority of people who have a pars defect don't have long-term symptoms with it. Now, I do talk about the red flag symptoms as far as, okay, if your pain changes, you start getting pain down your legs, that's a completely different discussion. But if it's intermittent back pain, it's aching, it's stiffness, there are people that go decades, never need this fixed, never need it injected, just keep up their core stability. And fortunate or unfortunate, we all should probably be doing core exercises all the time anyway, and it's just part of life.
Yeah, I tell people it's like brushing your teeth.
Yeah.
I think what's important here is that the patients the family members will catastrophize the word fracture here. They'll hear fracture and they'll look it up on Google, and that sounds bad. So you have to really de-escalate that terminology. We often say pars defect, even though it truly is a fracture, but it's an old chronic one most of the time. And so I think that's important. And yes, people live very functional lives, and sometimes these are found totally incidentally, meaning they just happen to get some sort of X-ray for some reason, or had one episodic pain flare up, and then they were found to have this, and everybody just can't get over the fact that you can live with something like this, and I think that's important. So, okay, you've tried your things, and then we got to maybe like 4 to 5 episodes a year. Seth, it's not totally the worst, but it's certainly more cumbersome. What do you think? He's come to you now.
Yeah, I think you got to add this one to the list of the 6 entities that I described. It's kind of the 7th.
Yeah.
And this is, to me, ideal scenario for a pars repair. So it's a 19-year-old normal disc, no spondy, minimal gap in pars. Not going to do a fusion here. I'll try a pars repair if they want surgery.
Yeah. And so that just describe for anybody who's not a surgeon here, what does that particularly involve?
Yeah, it is nice. Dr. Stewart was saying it is nice to have a diagnostic injection to establish that that is the pain generator.
Well, Mike, just so you know, you already did that. So
yeah.
Oh, yeah.
I do.
Yeah.
But on the other hand, it's like if someone comes in and they have back pain and they've got this pars fracture and they look like this, if they didn't get benefit from the diagnostic injection, would I still consider surgery? Yeah, I'd still consider surgery. I think it does make the prognosis a bit more guarded, but it's not a perfect test. So it'd be nice. It's nice to have that. Maybe it can help guide decision making, but it wouldn't be completely necessary. But a pars repair, there's a few described techniques. We try and do it with MIS techniques. It really depends on the anatomy and where you can put screws. That's what it comes down to. And these are the cases that I've had the vertebra 3D printed, so I can actually visualize the anatomy and plan out my screw trajectory, because some pars defects are amenable to screw fixation, meaning you can put a screw across the fracture site, achieve compression, and that's kind of ideal. That's primary fracture healing, and that's ideal. Other ones, for whatever reason, you can't put a screw across the fracture site, so you need to put fixation above and below and then compress across it. And there's a few different ways you can do that. One way is to put pedicle screws in L5 and then sublaminar hooks below the lamina of L5, and then you can compress those together. So that is one kind of common technique for doing this. Is that how you do it sometimes, Cliff? How do you do your pars repairs? No, but like from a technical perspective, do you? Yeah, so he's describing translaminar screws. So just like at C2, you can do translaminar screws. So if the lamina is thick enough at L5, you can do translaminar screws at L5 and then compress across those.
Compress across that.
Yeah, so there's a few different technical ways that you can do it. I think you can look at it online. I have this described MIS technique that I worked on with Alan Levy, who's the chair at Miami, and we published it when I was out in practice in Miami. CT nav is great. So I would try a pars repair on this bad boy. I mean, we don't do very many of those. I mean, I haven't done one in years. When was the last time you did a pars repair?
Oh, I've never done. Because my patients are always unhappy and old, and so they don't need that. Yeah. It's hard to find patients like this. This is not, this is a rare bird, but I think it's important to consider these options. Now, successful repair and healing, what would you say about overall activity long term?
If it heals. Mm-hmm. I think no restrictions. If it doesn't heal and they still have pain, then your salvage would be a fusion procedure. And I think if you're going to attempt a pars repair, I think you've already kind of committed to offering them a fusion if it doesn't work, as long as they don't, turn out to have
So
some.
you talk them through that aspect of things. And then from the standpoint of okay, so now I'm going to, change the story again. She is a collegiate athlete. You did that over the summer, would you let them go back to collegiate volleyball?
Yeah, I'd get a CT. I'd say, minimum 6 months. But these, patients who are 17, 18, 19, 20 years old, they heal differently, and so they can heal pretty quickly if they're going to heal. And so I'd probably say, minimum 6 months to return to comp, and CT confirmation of healing. And just as an aside for the residents here, when you only care about L5 on a CT, you can order a limited sequence CT of just L5, and so you substantially reduce the radiation exposure. I found that in order to truly get it, what you do is in all capital letters, in every free text sequence that you can, every possible one, you put limited sequence CT L5S1 only. And I feel like about 75% of the time it happens. And so then what I do is I coach the patient, I write it down, and I say, when the tech is putting you in there, you hand them this piece of paper and you ask them, are you going to do a limited sequence L5S1 only? And then you get like 95% of the time.
It's tough to keep that. Those kinds of things are tough to manage. Okay, perfect. I just want to bring up one more comment, make one more comment on what you said, Seth, earlier about patients being on the team or sending them for a mission. I think that's very important in patients that the indications are kind of tweeners. I think it's important for everything, but it's really important for this. You need to know that they're on the team, and so sending them for therapy or neuropsych evals and seeing what they do with that, or of course getting them to quit smoking. But all those different steps along the way, I often say those are really important ways that you're developing a relationship, and also seeing what that patient is really willing to do to try and get themselves better, because I think they're part of the team, in getting a good outcome is really contingent on them being willing to try new things, change their lifestyle, do those kinds of things, because that will help a lot. And then the other one is would you have a beer with them? That's what we always say, would you have a beer with this person? And it's 1 beer person, 2 beer person, no beers, make them pay for beers. But those are important, because it's really the pain itself is an experience, and so it really depends on cognitively or psychologically how they handle pain, and along with the biologic part and the social part, so that you have to get a better idea of what they're like psychologically as well. Okay, next patient is a 29-year-old woman with axial back pain. I do have some x-rays to show you as well, but you can see that there's degenerative disease at the L5S1 level. I know it's kind of light in here, but I'll just describe to everybody that there's some centrally protruding disc with some lateral recess stenosis, but she has no leg pain, just axial back pain. And she's had some injections that have helped. It's unclear why they've helped, of course, because they didn't have a specific target, and there's no spondy, and no instability on any dynamic imaging. So I'll give you some further context. I guess for Scott it doesn't matter as much, but just that she is a highly functioning individual. She works very hard. She's continues to work despite her discomfort, and really just finds that she has kind of this like unbearable pain with standing to some extent, but sitting mostly is what her big discomfort is. So Scott, if you would try to start with that.
Yeah, it gets hard, especially with sitting, and I'm guessing her job or occupation is sitting.
The nurse, but
So nurse, okay, well,
so she would be part-time sitting, part-time standing
Okay.
as an inpatient nurse. But
So at least she's got an out that way, because sitting, I can't, I haven't found strategic plans that actually help with that when you're forced to sit, except for better sitting posture, which is keeping your knees below your hips. But again, this is one where I am going to look for quite similar things. Is there something else causing this area to be stressed or overstrained through her daily activities or how she's choosing to move? Looking for reinforcement of function over pain or function without pain increase. It really isn't a bad thing. So quieting down the central nervous system sometimes is an important role in physical therapy or education for this type of patient. Yeah, these are tough ones when it's axial pain. They have a disc. That 85 to 90%, like I said, of nonspecific low back pain, this probably fits in there. They have imaging that gives you some clue or cause, but then why isn't it going away with the injection? And no ridiculous symptoms. So
I often say this is like the hardest diagnosis ever, because if they don't have any radiating symptoms, then you're just basically like, we'll get to Mike, but you start going through the process of trying to sort out the diagnosis. But the one diagnostic tool that we used to think worked didn't really work, which was the discogram. At any rate, core strengthening, those types of things.
Yeah, probably avoidance of prolonged flex positions. So, if you're at home at night, don't sit on your couch, the low seat, avoiding that until we can, at least get into flexion eventually. But this is somebody you'd exercise. You really don't want to rule any sort of exercise or activity out, but some education to calm down first.
So, for the residents and everybody else in the room, why do we think sitting's a problem? Because crazy enough, they put needles into people's discs years ago and then measured the pressure in different positions. And sitting, it's higher pressure. So that was
90 degrees in particular. So whoever wrote the posture books and did 90 degrees, the beer theme goes for this one. Bar stool height is probably the optimal sitting position for
there's so many good things
disc
about the bar.
herniations. Yeah.
Okay, Mike, if you could go ahead.
All right, so it kind of depends on what injections they'd had and kind of how they responded to various things.
They had a midline L5S1, and they were kind of like, maybe it helped, maybe it didn't, kind of thing. No, not a home run kind of.
Yeah, so I mean, you could always consider doing a bilateral L5 transforaminal. The thing on that, just making sure you're getting the good flow to it. With a midline injection, you're in the epidural space. With a transforaminal, you don't always. So if they had a transforaminal somewhere else, looking at that MRI, I would say, well, that actually looks pretty tight from the neuroforamen. At least that cut does. Maybe they couldn't actually get in.
Yep.
So I'd want to confirm, actually see the pictures from the injection to confirm it actually looked exactly how we want it to look.
I don't have those, unfortunately, but
yeah. And then I would try potentially the other one if I'm convinced it's discogenic. And to say I'm convinced, it would be on physical exam. You're not getting any SI joint provocative maneuvers. The muscles aren't particularly tight. PT and massage haven't been helpful. It doesn't seem facetogenic, especially in a 29-year-old. You could consider the other type of epidural injection. You had kind of touched on it, discogram. I didn't even mention it during my presentation because no one's done them for a long time. And in all reality, if I had this patient in clinic and they had all those injections and nothing helped, I would actually strongly consider getting a PET MRI scan from Dr. Biswal to see if the disc actually lights up, and that could be telling as far as what the underlying cause is. And I don't know if you guys have ordered very many of those. But on complicated patients, they've been incredibly helpful for me for back pain patients in particular when I can't find the exact spot. You don't want to fall into the trap of let's just inject it and see if it gets better. But that's where I'm leaning toward now with PET MRI scans that Biswal is doing.
Yeah, so I think those are great. I do think that, just like many things in our lives, the imaging as it gets better and the diagnostic tools as they get better might change how we talk about this. Right now, we just kind of like talk about all these different things that we do, and then eventually take a leap of faith. But I think that utilizing different methodologies of imaging is going to be key to what changes our world in the future. Like we'll just be like, oh, where's the pain generator? We'll just get this scan, and then we know it, instead of having to kind of do a lot of injections to start the process. What do you think about basovertebral nerve ablations?
So they just released 5-year data in the fall, and it looks astounding. It's not something I've done. I've looked into it, and when you look at the research they're putting out, it
Can you
looks.
describe the technique
Yeah,
a little bit, just so that
so basovertebral nerve ablation, essentially putting a trocar through the pedicle into the vertebral body, kind of curves around, it goes in to the posterior aspect of the vertebral body. So as the nerve comes in, you're ablating the nerve within the vertebral body. And traditionally, the nerve, like when you're doing a medial branch RFA, it has a path that it just regenerates through, and it's already kind of set. What they think is that with the trabecular nature of the vertebral body, that nerve doesn't essentially resprout to the exact same spot. And so you're treating the nerve that sends pain from the posterior aspect of the disc.
a rhizotomy of the disc.
Yeah. Yep. And so I had some initial questions about it because when they looked at MRIs a few months later, you're right next to the artery, and the T2 MRI signal was incredibly different 3 months after. And so one of my questions was always, well, what actually happens to the bony structure? Are we decreasing bone strength? What are the long-term outcomes of this? And one of the unfortunate things with pain, I'm sorry, I'm getting on a tangent. One of the unfortunate things with pain is that every 6 months, there's a new device that comes out, there's a new technique that comes out, and it's kind of overwhelming because pain patients are difficult, and people are always trying to create something new to treat something that we don't have a great treatment for. And so we in the pain world have very early adopters, people that are later adopters. I don't know, I feel like I'm probably a later adopter, but I feel like I'm in the middle. And I would like to start considering basovertebral nerve ablation for select patients. We don't have the device here yet. One of our newer attendings did some during fellowship and said that it worked really well. But again, that's limited follow-up when you're talking to someone who did a 1-year fellowship. But their 5-year data looks really, really good. When you look at their inclusion and exclusion criteria, they're trying very hard to really select for discogenic patients, and they are ruling out a lot of the patients with some of the psychosocial factors that Seth touched on. So how broadly applicable it is that you're going to get 5-year great outcomes from the Intercept procedure for discogenic pain, I don't really know, but their data looks phenomenal.
So I think that's what I think is important about that is, a new technique, right? But it's actually not that new, which is good. And just the reality that there is some data now looking into where the conflict of interests are. Is it an industry-led study? Those can challenge whether or not you can believe all that data. But I think, we do have to monitor those things, because this is the kind of situation where currently what we end up is going into the next step and considering it. But then there are a lot of people that are not going to be quite the patients that we want to do an operation on, or can, kind of add that to their list of challenges in their life. And having some intervening step might be worthwhile. But I think it's what's good and bad about being in an academic institution is sometimes you're trying to find, and you have people on staff that are kind of like on these cutting edge, and they're kind of doing oddball stuff. And sometimes, and many times, there's also the whole group of people that are like, you got to get some evidence for this, right? And so I think what we're finding with that procedure specifically is it's much more likely to be in a private practice setting than it would be in an academic setting. And if it turns out that it's helping everybody, it's going to be much harder for us to get it because of all the constraints of our organization than it would be if we were in a private practice setting. So I think that's important too. Okay, thank you very much. Seth, would you talk about what you might do? So now we've got a person, they're a team player, they're willing to do neuropsych, they've done all that stuff.
Yeah, I mean, if they've already seen Scott and Michael,
yeah,
I'm down to discuss surgery as an option,
yeah.
as long as they're normal person otherwise. And when they're in healthcare, they tend to kind of know the deal. Usually nurses and doctors are not too keen to undergo surgery unless they have to because they know what can happen. And so I find that helpful.
Yeah.
I would check BMI, the sub-Q tissues there where maybe it depends on where the weight is carried. And I might, give her a mission, lose 10, 15 pounds, something like that.
Exactly right.
And something
What's your ideal? I mean, I know I heard your ideal, but what's your reasonable like cutoff for BMI, as we say?
I mean, part of it depends on where they carry their weight. If they carry weight in the belly, that's not so great.
For an anterior approach,
right. So I think less than 25 is great. Less than 30 is probably okay, depending on distribution. Greater than 30, I'm probably gonna, not do a back pain operation on them. Whereas I would do other operations probably on somebody in the 30s.
Yeah.
And then something that I'd like to reemphasize is that when I first saw her in the clinic, I would not offer her surgery, and I would also not schedule follow-up. I think that if you schedule follow-up, sometimes people are just really good about that, and they'll come back.
Get engagement.
Right, and so if you don't schedule follow-up, they got to want it. They got to call, they got to make an appointment and come back in. They got to want it. So, it's one thing that I never do with the back pain patients after the first visit is I never schedule routine follow-up.
Perfect. Okay. Thank you very much, guys. Appreciate it. We're going to move on to the next topic. Try and get our afternoon fit in. Thank you very much. Here, I'll take that from you. Thanks. There. Okay. Okay. Now we're moving on to another difficult topic. Yes. Please go ahead. Oh, yeah, go ahead. Yep. Yes. So Dr. Schmidt is one of our newer partners within our neurosurgery department. He did his fellowship here and is really a nice, great, fast, thoughtful guy. He's going to talk real fast.
Yeah, sounds good.
Thanks.
So what is that? No disclosures, not too young to have any disclosures yet, so no one knows who I am. Cerebral spondylosis, so it's coming from the neck, neck pain, radiculopathy, and myelopathy. That's sort of kind of the main things we think about, right? This can come in a lot of different shapes and sizes, right? This is someone with a lot of degenerative changes, multiple disc space collapse. Someone you can have radicular parameters.
Yeah, I can hear you. Yeah, but for the WebEx. Yeah.
This is a large amount of osteophytic changes.
The WebEx.
This has a large amount of osteophyte changes. Right, so all of these would classify as sort of cervical spondylosis and degenerative changes that can be addressed surgically, potentially in the neck, and cause symptoms. So where do you start? So whenever I'm in clinic, I really break it down into sort of anatomical, right? So is it myelopathy, radiculopathy, or peripheral neuropathy? I won't, and again, this is with the understanding that we think it is coming from the neck, presumably, or nerve. Myelopathy, right, for those that are just kind of starting this, typically bilateral, typically affects the fine motor use of the hands, typically more distal than proximal muscle groups. Balance can be affected if it's bad enough, and you'll get upper motor neuron signs, right, because you, the motor nuclei, so you get hyperflexia, Hoffman's, maybe some clonus, and so forth. Radiculopathy, typically unilateral, although clearly, depending on the disc or multiple discs, et cetera, you can obviously have bilateral radiculopathy. I've seen it, I think we all have, but more commonly unilateral. Follows a classic anatomic path, right? We just heard about the shoulder, right? It doesn't kind of follow that dermatonal distribution. Well, radiculopathy hypothetically should, although again, as we all know, nothing's 100%. A lot of times we'll start in the neck and radiate down the actual arm, and then you gotta look for lower motor neuron signs, right? Hyporeflexia, and then peripheral neuropathy, even probably more commonly unilateral, although a lot of people with hyping they can have bilateral carpal tunnel, so don't get me wrong about that. But again, if it's a classic peripheral neuropathy, again, it should really only be affecting one site. And again, typically not from the neck down. It's usually from either elbow down, wrist down, or wherever that entrapment may be. And then, again, depending on where it is, reflexes may or may not be involved, right? With a carpal tunnel, you're not really going to see much in the way of reflex changes. And And so your examination is really tailored based on what you're expecting and what you're looking for, right? If someone's coming in with a lumbar radiculopathy, you're not going to do a lot of upper motor neuron things in the hands. But for the neck, a lot of times, again, you're doing motor, everything that you would expect. We won't hammer that home too much. Sensory, you're looking for pinprick, vibration, proprioception, all great tests. Look at dorsal columns. And then reflexes, like I said, right? So the main three that I look for, I suppose, in the upper extremity, although there are obviously more you can test, biceps, brachioradialis, and Hoffman's. Those are three sort of very easy, boom, 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 right down the arm, classic signs that you can look for. Hoffman's, I've found the more I've done this, can sometimes be very user dependent on whether or not you can elicit it. And oddly enough, you have to flick the finger a lot harder, is a real small technical thing, a lot harder than you realize to sometimes elicit that response. So just something for the younger residents if you're really looking at it. The other thing you have to realize too, and I always mention this when people come to my clinic, is that if someone is profoundly diabetic and has really uncontrolled diabetes, their normal reflexes may be hyperreflexic, for them, right? If they're inherently supposed to be hyporeflexic because their diabetes is so poorly controlled, if you see them and they're fairly normal reflexive, 2+ reflexes, then maybe for them that actually is myelopathy, right? So another thing to consider with that. If you're looking for radiculopathy in the neck, you can do a Sperling maneuver, tilt the head, push down, try to elicit that. And obviously with peripheral neuropathy, I'm not going to go into too much detail because we have Dr. Hannah here. You can do Tinel-Phelan scratch collapse test, obviously, as well. So imaging, again, if you're looking for something with the neck and cervical spondylosis, it's really going to come down to X-rays, CT, MRI, and then plus or minus EMG, depending on what you're looking for. And what imaging you want is going to be dependent, again, on what you're exactly looking for. Upright X-rays, typically I get on almost every single patient I see in clinic just because I want to have that sort of baseline data before I do anything. Usually that's enough. If I'm really worried about some instability, then I'll get a FlexX after that. But I almost always just start with standard upright. And again, that's just looking for overall anatomic alignment and then any motion or instability. CT scan, again, really looks at bone quality, osteophytic changes, OPLL, calcified discs. If it's a trauma, fracture healing, right? Sometimes the X-ray is just not enough, so you got to get that CT scan. And so CT is more of that. You can sometimes see disc herniations. It always cracks me up when you get radiology reads. They're like, oh, they're going to have an obvious radiculopathy based on the CT scan. I'm not so sure on that, but sometimes depending on the disc, you can see a little bit of that. MRI, though, obviously much more useful for the actual nerve structures. You'll see nerve and cord compression, disc herniations, myobilation, cord signal change. That's really important, right? If I've noticed this, again, very early in my career, if someone is profoundly myelopathic on the MRI, they have a lot of myobilation, T2 signal change from a big disc herniation. There's someone that may take longer to recover or may not recover. Maybe they're just, you prevent their symptoms from getting worse. Or worst case, they actually have a little bit of, whether you call it white cord syndrome, whatever you want to call it, after surgery, they can actually get a little bit worse before they get better because of that change you see in the spinal cord. So those are just important things to recognize when you're using the MRI. And then obviously, any other intrinsic pathology like tumors, infarcts, demyelinating phenomena, obviously that's a whole another lecture. I won't go into that, but that could be another masquerader of spinal pathology, things like MS and so forth. And then EMG nerve conduction study, I primarily use as sort of a confirmation type test, or if I'm really uncertain on something, I'll get that. But what I've found too is there's a lot of variability, like anything we do, but particularly in the EMG, and so there's a lot of options. So surgery options. You can go anterior, posterior. I'm not going to really go into all this now because this is what tomorrow's for. We're going to be able to explore and look into all these. But from an anterior approach, you can do your anterior cervical disc median fusion. You can do your arthroplasty, corpectomy, or odontoid screw. There are others. Those are kind of the main ones for the cervical spine. Posterior, laminectomy alone. Laminoplasty, for those that don't know that, that's where you basically fracture open, so to speak, the lamina and then bracket it with whatever you want to use, dealer's choice. Laminectomy infusion, you have foraminotomies, and you can do all of these either open or MIS, whether it's through a tube or endoscopic. And again, we'll talk more about these, and you guys will be able to explore more of these tomorrow. Just a fun, quick couple of cases just to kind of showcase some of this. This was a patient I recently did at the VA. Had a bad myelopathy. You can see that they have a subluxation of C5 on C6 and a very large disc herniation. The screen right at the top is the disc right through the disc level, and the shot below it is actually about 2/3 of the way up the C5 body. This was originally booked as a 1-level ACDF. We changed it to a corpectomy for two reasons. One, we thought that that would give us a better reduction of that severe subluxation of C5 on C6, and then it will allow us to better get that disc herniation. And we're really glad we did that. This was the post-op result, because that disc, again, did travel about 2/3 of the way up the body, and it was actually more calcified than we sort of thought. And so that was a benefit there. This was a bad trauma. This patient fell in the shower. As the EMS moved them, he became locked in, and then by the time he got to the ER, he was neurologically intact again. You can see that the DENS is pushing into the brainstem, and so with that minor movement from the EMS, he actually had brainstem compression intermittently. So we took him to the OR, we put him in traction, reduced him, and did an OC fusion. Something I like to see on this X-ray is all that bone fusion mass behind the screws. That's a very good sign for OC fusions. So you don't often see that sometimes. It's very hard to fuse the occipital-cervical junction just because there's so much motion there. And then this is just an interesting last one. So this is a patient that had a previous 2-level ACDF, not by myself, but elsewhere, who has adjacent segment disease, the level below. You can see in the middle MRI, quite a bit of stenosis there with a little bit, if you kind of hallucinate, some mild malacia, T2 signal change there. This patient, well, you could absolutely do another ACDF. You could have, how dealer's choice, right? This patient was deathly afraid to go back from the front, not because anything happened the first time, he just really didn't want to. So I thought this, and you can see on the sagittal view of the MRI there in the middle of the screen that a lot of the stenosis is actually coming posteriorly from overgrown ligament. And so I actually did an endoscopic laminectomy there, and this is just 3 quick sequences. This is just, the screen left is showing the ligamentum flavum that you can see. Midline is a screen top, and then lateral joint is left, screen bottom, and then left is would be C5 and C6 or whatever level was. The middle shot just shows the early stage of starting to decompress, do the laminectomy and decompress the ligament. And on the screen right just shows much more significant laminectomy and ligament removed to show the exposed dura. Very quick.
Perfect. Thank you very much. Thank you. Thank you very much, Brad. That was great. And we'll get more discussion in the cases here. So now we have Dr. Hanna is going to talk about nerves, and I think this is really important because this is kind of the missing link in all this diagnostic workup, of course, treatment as well, but knowing about what other kind of nerve-related, brachial plexus-related symptoms can be similar to cervical spine pathology is very helpful. There's nothing worse than treating somebody for their C6 radiculopathy when it's carpal tunnel. That's really an uncomfortable scenario.
Thanks, man. And Dr. Orwin, I loved your title. Is it the spine or the shoulder? What if it's not the spine or the shoulder? I think the theme is matching very well here. There's a ton of stuff between the spine and the shoulder, and what if it's in between? And the things that we could see in this location, inflammation, like Parsonage-Turner syndrome, you could have a brachial plexus tumor in that location. And you can have nerve entrapment. So you can have suprascapular nerve entrapments, or people who described also dorsal scapular nerve entrapment. I haven't seen one of those. And of course, thoracic outlet syndrome. So keeping this in a case-based approach, I'll show you some cases. This was a 37-year-old male watching Super Bowl and experienced severe pain in the right shoulder, no history of trauma. And then the typical story, the pain subsides, but then weakness sets in, and he gets a scapular winging. And this is his picture. When he presented to us, you could see the prominence of the medial border of the scapula, and that's typical scapular winging. So the differential here, you have to think about the muscles that insert into the medial border of the scapula. And this morning I was trying to put it into ChatGPT, make a figure showing the muscles inserting in the medial border of the scapula. There was no way. It keeps putting medial border on the lateral border. I said, just give up. So I didn't do the diagram, but 3 main muscles that could give you winging of the scapula: serratus anterior with the long thoracic nerve, trapezius with the spinal accessory nerve, and the rhomboids with the dorsal scapular nerve. So any one of those could give you winging. You do the EMG, and there are two nerves completely unrelated, like the long thoracic and anterior interosseous nerve that goes along with an inflammatory process. And the treatment is typically conservative. Again, story typically severe pain, the pain subsides, and then you get the weakness. And then it could follow surgery, trauma, post-viral, and then the EMG confirmatory, and then treatment mostly conservative. Occasionally, you get a patient who has residual weakness long-term, then we can think about doing nerve transfers for those. And there he was 5 years later. You could see the winging on the right side is almost completely gone. Next case, 53-year-old, sharp burning pain, almost similar story, radiating on the left side of the neck, up and down, and denies numbness, tingling, or weakness. Normal exam, and there was a lump behind the sternocleidomastoid. And after imaging, the lump was biopsied and came back as schwannoma. This is the typical MRI findings of a benign nerve sheath tumor. On the left, you have the T1 showing the lump as iso-intense. In the middle, you have the T2. There's hyper-intense signal on the T2. And then on the right, you have a sagittal with contrast, showing the contrast enhancement of the mass, typical for a benign nerve sheath tumor that highlights the importance of imaging the brachial plexus if the spine imaging does not make sense with the patient's symptoms. And of course, this one would require a tumor resection. Next, 58-year-old male with a 4-month history of pain in the shoulder and weakness, mostly abduction and external rotation. So you have to think supraspinatus and infraspinatus. 4+ shoulder abduction and 3 external rotation. The one nerve that goes to supraspinatus and infraspinatus is the suprascapular nerve. And contrary to the scapular winging, the prominence here is the spine of the scapula, not the medial border of the scapula. And the spine of the scapula is prominent because supraspinatus and infraspinatus are atrophic, which goes along with the suprascapular nerve neuropathy or nerve entrapment. You complete that with an EMG. And then here's just a short video showing you how we do the surgery. Patient could be laying prone or lateral. You palpate that spine of the scapula and you make the incision along the spine of the scapula. You want to bice it above that, so cranial to the spine of the scapula, that's your target. And the muscle layer you go through is really just the trapezius and the supraspinatus. So trapezius, you mostly go in between the fibers, but you still have to disinsert part that you have to suture at the end of the case. And then the supraspinatus is wrapped in another fascial sheath. So you have to open that fascial sheath to be able to see the supraspinatus muscle. Once you open that plane, you should be able to palpate the upper border of the scapula. So with your index finger, you push the supraspinatus down, or caudally on the patient. You palpate the upper border of the scapula. Here you could see the vessel superficial to the ligament. The nerve is deep to the ligament. And the tool here is going in the suprascapular foramen or suprascapular notch. The ligament you could cut with scissors, but over time I found it easier to put a Woodson tool under the ligament, and then the resident would cut with a 15 blade, and that concludes the surgery. Sometimes I take a Kerrison and I widen the notch a little bit. And there he was 3 months post-op. You could see filling up the supraspinatus and then starting to fill up the infraspinatus fossa as well. Next case, 58-year-old female, 12-year history of numbness of the left hand and also weakness. There is atrophy, thenar, hypothenar, and first dorsal interosseous space. This is typically described as the Gilead-Sumner hand. And here you have the atrophy and weakness involving 2 different muscle groups, 2 different nerves. So the first dorsal interosseous is ulnar nerve. The thenar eminence is median nerve. So where the 2 meet would be up here, either medial cord or lower trunk of the brachial plexus. So you have to think about thoracic outlet syndrome, Panco's tumor if you have a smoker. One of the maneuvers we do for thoracic outlet is the Roos test. You have the patient exercise overhead, and you look for reproduction of the symptoms. And you could also see the color change in the left hand here, completely white when he exercises, because there's always an arterial component to his thoracic outlet, even though it could be predominantly neurogenic. That's a different patient from the one I presented. but it's good to see that. Back to that same case I was showing, the patient had a cervical rib. You could see the rib, incomplete rib attached to C7 on the left side. And the EMG, you have to be very careful with the EMG, because if you don't have an experienced neurologist or physiatrist doing the EMG, this could be mistaken for carpal tunnel syndrome. The main difference with carpal tunnel, because this is the lower trunk of the brachial plexus, it involves the motor part of the median nerve and not the sensory. Carpal tunnel is the other way around. Carpal tunnel involves the sensory, and very delayed, it could involve the motor part of the median nerve. So workup for thoracic outlet syndrome, vascular studies with ultrasound, the arterial and the venous, do it with the arm down and the arm up, the MR neurogram and MR angiogram, and you do it with the arm down and the arm up, looking also for pinching of the artery and or the brachial plexus. Treatment, you start with physical therapy. You can do Botox injections to the anterior scalene. Treatment, our preference is the anterior scalenectomy. Our colleagues from vascular, they prefer first rib resection. We like to save that for the venous thoracic outlet. And occasionally, if somebody doesn't respond to the scalenectomy, we look for the pec minor, get an injection there. And sometimes we do a pec minor release. This is the typical positioning for a thoracic outlet surgery. We go along a skin crease in the neck in the posterior triangle, contrary to your ACDF, where you go anterior to the sternomastoid. We go posterior to the sternomastoid for the brachial plexus and thoracic outlet. You meet the omohyoid, you cut that, and then the transverse cervical vessel, you have to ligate those and cut them. And then usually you get an upside down view of the brachial plexus. So the bottom is going to be C5-6, upper trunk, C7 to middle trunk, and C8, T1 to lower trunk. And then most caudally would be the artery. Medially, you see the phrenic nerve. When you stimulate phrenic, you see the chest wall rising as if they're having a hiccup. And if you look at the end-tidal CO2, you see changes in the wave of the end-tidal CO2 when you stimulate phrenic. This was the case of a cervical rib. So we retracted between C7 and C8 to take that cervical rib out. So in summary, you have to listen to the patient, and completely agree with you, Dr. Orwin. Ask the patient to take one finger and point to where the pain is, especially with back pain. People would say, I have back pain, but when they point to it, it could be a SI joint pain, could be even piriformis level pain. So this is a very good test to ask the patient to point to their area of pain. You have to examine them carefully, look for a Tinel sign. Scratch collapse test is very helpful, and Darius volunteered to demonstrate that. It's very useful, especially if you are doing spine. And I found it positive also for spine, for the paraspinal muscles. So I asked the patient to put their arms like this, and then you're pushing, and they try to resist your push. And then you scratch different areas where you think the nerve is irritated, and then you push again, and they're resisting. For radiculopathy, I find it positive with the paraspinal muscles. And then for ulnar neuropathy, it's at the elbow. So you look for that collapse when you irritate that area of skin. Thank you so much. It's controversial, so not everybody believes in it, but I find it very helpful, especially when you're not sure, or what we call double crush syndrome. I think we overcall the double crush syndrome. I think if you do the scratch collapse, you may be able to narrow it down more. Check the pulse, obviously, for the Adson test if you're suspecting thoracic outlet syndrome. If it's not straightforward, get an EMG. And if the spine imaging is negative, you can always image the brachial plexus. And if nothing makes sense, you can always in-basket me and we can think about it together. Thanks.
Thank you. We're going to try and do one case. I know we're a little bit behind schedule, but we'll hopefully have time to make it up in the afternoon. If you guys would just have a seat there. I'm glad if you keep your mic, and then I'm going to hand Brad these two. So obviously I've given away a few things, but the 60-year-old with shoulder arthritis and C4-5 foraminal stenosis, we can see on the MRI scan at the C4-5 level, we have some cervical spondylosis. There's also some at C5-6. And then at the axial MRI, you can see left-sided foraminal stenosis from a disc posterior disc herniation. And then another view that's nice on the MRI scans these days is the oblique foraminal views, and that shows a foraminal disc at that level. This is a video of that. So this is on the left side. You can see just a pretty significant amount, severe stenosis of that foramen. And of course, the patient's complaining of left shoulder pain. And because their primary care physician listened to them entirely, got imaging for both. So we have imaging for both. This is the series of shoulder x-rays, which I can't propose to actually say other than there's some arthritic changes there, but maybe Dr. Orwin might have some comments on what he sees.
Yeah. Well, yeah, this shows clearly that the person's got on the right view, excuse me, bone on, that's the AP, what we call AP near shoulder. So you're looking right down the glenohumeral joint. And there's basically no space between the glenohumeral joint. There's this is a scapular Y view, which for the arthritic component is kind of worthless. It shows he's got some, it doesn't look at the glenoid. So the best two views, if you're going to pick two views, and maybe you've got it, you'd want the AP view and an axillary view. And there's the axillary view, and there's some overlap, but you can clearly see there's no joint space. And I would tell you that this person's subluxed a little bit out the back, which is common in the arthritic shoulder. So one of the, we talked a little bit about, I talked a little bit about how most of the pain in the shoulder disorders is more anterior lateral. Arthritis, classic arthritis in the shoulder is one of the few things that does hurt more in the back of the shoulder. And that doesn't mean that there's more arthritis in the back of the shoulder, but in some of the chronic scenarios, when you get that subluxation and you get more wear of the posterior glenoid, they will often have more posterior shoulder pain than you typically think of when all these patients come in with their rotator cuff problems and all the other types of things. And that's actually played a big role. That arthritic wear, especially posteriorly, has played a big role nowadays in terms of the treatment options for these patients if you believe the only treatment option is going to be an arthroplasty. And that's why you'll see the shoulder doctors now not doing classic joint, what we call anatomic joint replacements, because there's such a high failure rate in the glenoid component. And so you're hearing people getting these what are called reverse shoulder arthroplasties, and the reverse shoulder arthroplasty allows you to not deal, or allows you to not have to deal with that posterior wear in the glenoid.
Interesting. So obviously this patient, you don't get to meet them, but in your case, I'm going to just give you your case. They have a lot more pain on exam in the shoulder than they would with any kind of Sperling maneuver. They don't have any numbness in the C5 distribution, and no deltoid weakness other than what we would see from the joint pain itself, or atrophy, I guess would be the other thing that sometimes see. So especially in this age group, we see this not uncommonly, that where they've kind of gotten both sets of diagnostic studies, and we're kind of trying to sort out what the plan is. I typically would put more stock in the active and passive range of motion testing in that scenario. And then some of the history things that I find helpful, and I'll bounce this off you, is like carrying any kind of bag or anything in that hand. Does that really aggravate them? Those kinds of things.
Well, yeah. And so when does the pain hurt? Shoulder pain classically bothers a lot of us at night. So does this wake you up at night? Are they fine during the day? And everybody goes, why does it hurt at night? I'm not doing anything at night. Well, I like to say that most of the shoulder stuff that we see isn't the worst pain in the world. I think personally, true nerve pain, and you could argue everything's nerve pain because if you didn't have the nerves, it wouldn't hurt. But true nerve pain, true radicular pain, true neurologic pain, as opposed to, in this case, bone-on-bone arthritis, Bone-on-bone arthritis tends to give you that dull, achy kind of nuisance pain. Nerve pain tends to be more severe. That's just been my gestalt in 40 plus years of seeing patients and taking care of patients and stuff. So when do they hurt? Nighttime pain, classic for the shoulder. All the rotator cuff stuff keeps you up at night. Arthritis keeps you up. You know, it's a non-weight bearing joint. You're out doing stuff during the day. You're not thinking about it as much. So when it hurts, where it hurts is important. They might hurt all over. Very common for their biceps to be all beat up. A lot of these patients also have concomitant cuff disease, so they can hurt everywhere around the shoulder. I mean, you look at this and you say, well, is this just the arthritis? Well, it's not. The biceps is a player still. Whether if you're going to do an arthroplasty, then you need to know the integrity. I need to know, let's say you don't necessarily, but I need to know the integrity of the rotator cuff because that's going to change whether you do a reverse or something like that. Now, I'm old school because for years when we didn't have good arthroplasty, I didn't have a lot of treatment options short of just going in and scoping these shoulders. And I would scope these shoulders and debride their shoulder joint, clean out the joint, do a synovectomy, get rid of the biceps, get rid of the other kind of just generalized pain generators, and doggone it, a lot of these patients did very well. When we looked at our patients at 10-year follow-up, less than 10% of these patients were going on and having a joint replacement. Nowadays, I call them all you youngsters are like rushing right off to do a joint replacement, which in a 50-year-old, in a 70-year-old, that's still okay health-wise and stuff, that's fine. But some of these lesser procedures, especially in the shoulder joint, work. It doesn't work in the hip. It doesn't work in the knee because they're weight-bearing joints, but it works in the shoulder. So I might inject this person. That's a very valuable thing to see how it changes their symptoms. If they have some of these patients, you look at the radiograph and they go, oh my God, there's no way this is going to move. And you check their motion and they've got great functional motion. So that surprises you. And those are patients actually with an injection, they might feel better, but with a simple debridement, they might get a lot of relief to the point where they say, okay, this is livable and we don't need to do anymore.
What is the injection that you order? Because this is something even I need to learn. Do we order particularly for a particular joint space?
You tell them you want a either fluoro guided or ultrasound guided, and it's the choice of the radiologist. And because the problem I have with doing it in clinic, and believe me, I've stuck more things in the joints in 35 years than most people, so I can get into the joint. But if I send them to the radiologist, I have about a 99.9% chance that our radiologist is going to get it exactly where I tell them to. And so I say you do their steroid and lidocaine and marcaine cocktail into in this case, the glenohumeral joint. They fill out, it's absolutely crucial, they fill out a pain diagram and their pain survey, and you get a sense on how they felt. And, if they get a good response and it lasts, well, great, it lasts. And if you get a good response, but it doesn't last, well, then they're a candidate for the next step, which would be, in my hands, I would, especially if they had good function, good motion, I would consider a debridement. If they have crappy motion, if they really have bad motion, then the debridements, arthroscopic stuff doesn't work as well. Then they're probably looking more at the bigger joint replacement type of procedure.
Perfect. Thank you very much. Question. Yes, go ahead. I would say you send them to ortho.
Yeah, you don't need to send them.
Because
if you're really not sure and you want the Jimmy Leonards and the people like that and Mike Sewers of the world who are brilliant at sorting out some of this odd stuff, then going the PMR route is fine. You could order the glenohumeral injection in a case like this and then send them to ortho and get the follow-up and have them see how, after the discussion with one of the shoulder people, what's going to be the next step. Sending them to therapy is okay. The problem with this group, all the other patients should go to physical therapy. You don't want to send these people to therapy and let the therapist beat them up. So you can't just say send them to therapy with the PT order saying do PT and not explain to them that they've got bad arthritis and stuff. Because if you try to push them too hard in PT with the bad arthritis, you're just going to make them worse. Whereas most of us with bad cuffs respond very nicely to appropriate physical therapy.
And again, the test for rotator cuff is the can test more. So.
Yeah, the empty can is the classic. You're testing the patient in the scapular plane, which it's called the scaption test. And so the empty can test tells you if the supraspinatus is weak. Problem is, what else holds your arm up there? Your deltoid. So lots of us are running around with good rotator or terrible rotator cuffs, and we can hold our arm out. But if you, on the other hand, if you hold the arm out and or you have them try to hold the arm out and it just drops, or they have the positive drop arm test, that's the opposite is very true, that they probably have a significant cuff tear. But if you check their posterior cuff and they're not weak, they certainly don't usually have a big rotator cuff tear. And nowadays, people are going to get either, or especially if they believe they're headed towards a joint replacement, they're going to want to know about the integrity of the rotator cuff, because then that changes the type of arthroplasty they we're going to do. And some of the newer studies are suggesting that we may actually stop doing conventional arthroplasty and just do these reverse shoulder arthroplasties, because the recovery is a little easier and you don't have all the other complications with respect to the glenoid. But an injection can really help sort out what's their function and things like that. And the therapist can help you with stuff like that.
And my recollection of the reverse shoulder is that it's the ball's on the scapula side and the cup's on the.
Yeah, somebody in Europe, I'll just say, it sounds like they screwed up. They put the ball where the socket's supposed to be in the socket. Somebody's like, you got to be kidding me. They put this upside down. But it makes good sense, because what happens is they designed it in the setting where you don't have a rotator cuff. And what the rotator cuff really does in your shoulder, it's not yes, it elevates your arm and stuff, but really what the rotator cuff does in your shoulder is it depresses the humerus into the glenoid. So it's a stabilizer. Your deltoid is your primary mover of your shoulder. You're going to see tons of people with crappy rotator cuffs that function great. You'll never see anybody with a bad deltoid function well. So don't ever do anything to screw up the deltoid. It's the most important muscle by far in the shoulder. So what happens is, if you do a real normal conventional arthroplasty in somebody without a rotator cuff, they just ride upward and then the glenoid fails and it's miserable. So they figured out by putting the ball where the socket is and the socket where the ball is, it acts as a way to depress the head into the glenoid, and then the prosthesis itself acts as that stabilizer.
Got it.
So you don't have to worry about the supraspinatus and infraspinatus.
Perfect. Thank you. Brad, so now we're going to transition into, okay, really clinically much more positive Sperling sign, deltoid, a little bit of deltoid atrophy, certainly weakness, and the shoulder testing really doesn't show anything. How are you going to manage this now?
I mean, they have a lot of weakness in their shoulder now.
Yeah, pain, weakness. So certainly more like a C5 radiculopathy.
Yeah, I mean, if they're having weakness, they've gone through, the typical medical therapies and so forth, and I think proceeding with surgical decompression is very reasonable. If there's any diagnostic concern at all, I don't order a lot of cervical transfemoral injections. They're just not as They're a little bit more intense for patients, I think, than lumbar, so I don't order a lot of them, but they are useful from a diagnostic standpoint. So if there was any real diagnostic concern, you could get an injection. We talked about EMG, neuroconduction study. Again, if there's any diagnostic question, you could get that. I would get that again more as a confirmatory if I'm trying to rule out something else specifically. But assuming all that checks out and they're a decent candidate, I think proceeding with the surgery for decompression is a good option. At that point, it's a lot of dealer's choice on that. You could probably ask the 6 different spine surgeons in this room. You might even get 6 different answers about how to do this. I think ACDF, whether you do 1 or 2 levels is reasonable. Posterior cervical foraminotomy is reasonable. Then if you're going to do, are you going to do a if you do the foraminotomy is endoscopic, is it through a tube? I mean, right, the list goes on and on. And so, but I think I would be very reasonable based on that description to proceed with surgery.
Yeah, so I think, sorry, I'm trying desperately to get back to where the original images are, but yeah, the idea of how many different ways can you fix this problem in spine surgery is it's very important to recognize for everybody else here that this is one of these situations where you could show this to a group of spine surgeons and they would say, oh, you got to do 2-level ACDF, or you got to do a posterior laminoplasty, or you got to do single-level foraminotomy because that's where only the symptoms are, and the patient's not myelopathic. And so you'll hear a lot of different options, and there's still just, unfortunately, no data to support one or the other. Specifically, it's more like whatever the person feels like works best in their hands. The challenge for the referring providers, and we're going to say the pain service and in our group, the pain service, the PM&R doctors, is like identifying and knowing enough about these procedures, which one's more like on the higher end of invasiveness, or what does it do downstream, and hopefully having an idea of which surgeons you can send people to that will think through it and not just automatically go to the biggest, most highly reimbursed operation and kind of think through it. Dr. Orwin, of course, maybe he followed my advice. Like I tell all the residents, don't buy really expensive cars and really expensive houses when you first start, so that way your indications can be good, and then you're not just like trying to pay for all these things, and then you just kind of advance your indications into all these kind of highly reimbursed procedures. So you figure out what you need to do so you can do a good job for the patients as a surgeon. I think is very helpful, and I think that's an important take-home message, because once you leave residency, you'll find that there's a lot of different types of pressures on what makes you decide on things. So, which may be why the junior guys are all doing reverse shoulders when you're thinking about it. Yeah.
I may go down in history as one of the most conservative shoulder surgeons in the world. No offense. I see lots of my patients out in my dark, out running around, and they'll poise their arms up, they go, doing great, and you didn't even do surgery. So there's a lot of things you can do without, with good therapies and all kinds of other treatments that don't result in me taking somebody to the operator.
Okay, so perfect. Thank you, Dr. Hanna. So obviously, another valuable thing to know about these is that the imaging can look exactly the same when these patients come to see you, but the problem can be completely different. So now the patient comes to you because he was seen in the emergency room because of severe unremitting pain in his arm, really bad, terrible, maybe had a little something like upper respiratory infection a few weeks before. And then, of course, diligent emergency room doctors did every test they could possibly do. And then eventually they said, okay, we'll go see a neurosurgeon in your case. So just with that history, what are you thinking?
Sure, you definitely always have to rule out Parsonage-Turner syndrome. And whether it's radiculopathy or Parsonage-Turner, you're probably going to treat it conservatively at the beginning anyways, and then get an exam on the patient, see you're leaning more towards radiculopathy, leaning more toward brachial plexus. And then EMG, you can't really do an EMG within the first 2 weeks because it's not going to give you a lot of information. So you have to wait like 3 weeks. If their symptoms persist for 3 weeks, then you can get the EMG in a delayed fashion to try to sort it out. And you can always do an MRI of the brachial plexus if you're highly suspicious of something in the brachial plexus. Occasionally, there are findings during Parsonage-Turner syndrome, but you could have a completely normal brachial plexus MRI with a Parsonage-Turner syndrome.
Yeah, so I think that's what's really hard about that scenario is that the patient's typically weak. And of course, the mindset for the surgeons is to operate because they're weak. But typically the distribution of their weakness will be in multiple muscle groups. Distribution of their pain will be in multiple dermatomes. Depending on the timing, you may see them when they have some atrophy. You may not. You may be so early on and that's kind of the very common boards scenarios like this, where they give you this patient and they show you all these studies, and then they give you that history, and then you go and operate anyway, and then they start like destroying you with all the complications that you caused because you operated on somebody when they actually had a different diagnosis to begin with. So I think it's very important to keep that in the front of your mind. It's actually, I don't know, I've seen it so many times, I can't even, think of it as like a weird diagnosis. It's actually very common. Yeah.
Yeah, it's very important to educate the patient, whether it's Parsonage Turner or if you do a nice operation, you get a C5 palsy post-op. Important to educate the patient that most of those would reverse over time. It could take some time. It could take months versus year for it to recovery. And if it doesn't, if you still have a weak deltoid by 9 months, we do have options for those nerve transfers from radial to axillary is a bailout option if nothing else works, if the foraminopathy doesn't work, or if they still have residual weakness after everything we have done.
And I think that's a really important point, there is that option for improving the strength of the deltoid that is out there, but you have to employ that soon enough before the muscles atrophy. So what's the timing, do you think?
It depends. For Parsonage Turner and post-op C5 palsy, we tend to wait because they tend to reverse on their own. So I push that one to 9 months, although the typical brachial plexus injury would be 3 to 6 months. But for those two pathologies, I would wait longer.
Just to see what the recovery is like. Yeah. But okay, perfect. Any other questions? Quick question. Yeah, go ahead. Yeah, I use the diagnostic side versus the therapeutic side. So yeah, that's the first 8 to 10 hours might be the Marcaine or whatever they end up using for the injection, and then the delayed effect is more of like a therapeutic effect. And so if patients don't get a therapeutic effect, at least we know we are probably at the right level as long as the injection looked like it was done at the appropriate level. And of course, you want to talk to them about what symptoms got better. Some people are like, oh, my neck pain got better. That's not really what you're trying to fix. So you have to make sure you have that as well. Yeah, so in the early phases, and that sometimes isn't even captured in the diaries that are given to them. Sometimes it is. Ours here they are, but you just have to be cautious about that. That they may be like, oh, it didn't work at all, and then you ask them, and they're like, oh yeah, the first day I was great. Like it felt really well.
The diaries are crucial.
Yeah.
When we switched to the diaries years ago, it made a huge difference. You just stress how important it takes 2 seconds just to
Right.
and even if you do it for the first, you set your alarm clock or your watch, everybody's watching on the day doing information about it.
Yeah.
It beep every hour. Putting that information down is really helpful because you're right. Basically, well, that didn't work. And you look at the diary and go, wait a minute, you went from a 9 to a 0.
Right.
It might not have lasted, but that's really relevant.
Their interpretation of working is like they're gone. They don't need to see us again. Yeah. Thank you very much, everybody. But for those of you, I think everybody in the room knows Dr. Leonard, but for those of you who don't, Dr. Leonard is one of our PM&R or rehabilitation specialists who has been very, very, very helpful in kind of bringing together spine and spinal surgery and non-operative spine. And I think has been really a great friend to both orthopedics and neurosurgery spine in helping us figure out the difficult patients, the patients that we may not be able to help, but still need help in some way. And I think that's really valuable because I think the old model of spine surgery certainly was nothing for us to do here and then just send them out the door. And now we kind of have a better way of saying it, which is no surgery, but here's somebody else. And that's what Dr. Leonard's going to talk about. And he may talk about some other things that are important too. And I'm looking forward to this talk. So thank you very much.
Good.
Appreciate it.
Thank you, Sam. Thank you for inviting all of our re-up group. We're honored to be here. So I'll get important things out of the way first. So Dr. Sewer is always talking about getting a Porsche 911. What I have here is my Iowa version of a sports car. It's a 1974 Chevy Vega GT. It did have a 4 on the column, on the floor, by the way, so it was really cool. But unfortunately, they didn't make them very well. The 4-cylinder aluminum engine was not meant to last perhaps more than the time the lease payments would go through. So, so I just let him know I'm a sports enthusiast too, and you can share them with that. He can't get ahead of me. So I started this 51 years ago. I was a physical therapist at a very nice hospital in Dubuque, Iowa. We had a very enthusiastic group, excellent group of physicians to work with, and it was a very enjoyable experience. At that time, it was interesting. Insurance will kind of run the pathway as far as what's done. And at that time, they would not cover outpatient physical therapy that much. And so patients would be admitted. So we would have patients inpatient for 1 to 2 weeks in traction, either cervical or lumbar. They would get all sorts of heat modalities, ultrasound, massage, the basic exercises, but not a lot. And so it was a different time frame, a different attitude. And unfortunately, I think the worth of what we were doing at that time was right there with the Chevy Vega. It really was too much passive. And as Scott Toffner was saying this morning, he's much more active on the exercise approaches, and that's the way it should be. There were, from my days in therapy, I think the biggest issue was you got to make the patient responsible for their care. You can't take it on yourself. So, and that's, I think, the theme we're seeing here is you have to, as far as looking at a biopsychosocial model, you look at the whole picture. And if they're not going to do it, I give them options. But if they don't want to go with it, and actually, what I try to do is I try to give them 3 options when they come into the clinic. And it's really interesting based on their attitude, which one they're going to go with, as far as just going ahead with the rest the way they're doing, using medications or going to injections, or they just want it fixed. You want to see the surgeon? If it's appropriate, we'll do that. And I'll say, otherwise, I'll say, look, you're going to waste your time. So it's always interesting to see what option they want. The lady that came in and says, you know, I just want to be disabled. That's very clear cut. I like that kind of picture because it's very concrete as far as what you can do. And so you don't waste a lot of time. But the most important thing to do is aerobic exercise. We got to hone that in. Everybody goes out the door. Whether you're rehab, whether you're a surgeon, you can have a big influence on what that patient will do. So you got to get them moving, especially individuals with stenosis. It's a real problem. So the most popular tool that's out there now is a new step machine where they're sitting. And when they're sitting, usually it doesn't stress the spine near as much. Or a recumbent exercise bike, or if they're really ambitious, they get in the pool. If you get the water up to your chest, you get about 75% of the weight off the spine. But that's not as popular in Wisconsin in the winter. Yes, we use the medications. I'll use some narcotics. We'll talk about that. But really, you got to keep it simple. A lot more literature out now about all the adverse effects of the nonsteroidals, especially on cardiac issues. Especially on the kidney issues. And so we're not pushing them near as much. And I think what the really good physical therapy will do will work a lot on teaching the mechanics, how do they recognize aggravating leaving factors and get them going on that. I'm a big fan of the inversion table, as long as they're not older, as long as they don't have ocular hypertension or cardiac issues. Patients are very compliant with that. And so not having going all the way down. If they just go down to about 45, 50, 60 degrees, you'll get a good benefit out of it. But I just have them do it repeatedly. The same with the cervical spine. The traction devices lying down are much better as far as patient compliance, and also the patient's able to get a better traction. You really don't need to go heavy with that. If you go up to about 12 to 15 pounds in most cases with a intermittent device like this, or just a static traction. With a lot of facet DJD, if I test them in clinic and they get a lot of relief from it, I will have them get that at home because it's so hard to get in for the therapy. It's so backed up that it's the simple things I can do at home can really pile it on. So I talked about the active exercises. I think a positive attitude from the therapist, from the physician is huge. I was mentioned earlier about getting an individual with a psychologist. A minority of the people I see will do that, but those that are having a life crisis, that are post-traumatic stress, that have a huge anxiety issue, it's really quite effective. Exercise compliance is low, so everybody needs a follow-up. You can't make them, they don't love exercise. If they feel guilty about it, maybe you'll get somewhere, or you threaten them with a 4-inch spinal needle, but maybe that would get them somewhere along the way. So there was a neat article that a group down in the physical therapy group down in New Zealand, the NOI group they're called, they really looked at a good way to explain patients to patient, and also for us to break them up as far as looking at other options. It's very frustrating. I will see someone that has tremendous arthritic changes. They'll have headaches. It looks like clearly it's going to be a spinal stenosis. But what I do is I'll get a C-reactive and C-reactive protein, and it turns out to be an inflammatory disorder. So a lot of times I get too much going down one pathway when I really should be more global as far as what I'm looking for. I had a guy that had back pain. He went home, he kept falling, he kept injuring his back. Well, it turned out he had a neuropathy. He couldn't feel where his feet were at. He had no sense of balance, and it was all a neuropathy secondary to poorly controlled diabetes. So looking at these other issues is really a problem. Central mediated pain, that's a little different animal. I'll talk about that. So the neurovascular compression, this is what a lot of this conference is about, the mechanical back pain. That's been quite well covered. The neuropathic, I get the most good out of using a 128 hertz tuning fork down to the feet. I'll touch them with my hands and they say, yeah, I feel that, I feel that. They'll feel pinprick, they'll say, yeah. But with the tuning fork, it's much more discriminatory. So I think Dr. Resnick had us fill all our clinic with the tuning forks, and I think that's been extremely helpful just to differentiate that neuropathy along the way. Then if that's the case, I'll get the EMG and try to quantify how much is there. Or if it's a vascular issue, we'll send them over and check their peripheral vascular studies, ankle brachial index and that, and it'll change our approach quite a bit. The inflammatory, we're seeing more and more of this as we get more elderly, where you start getting the pannus, for instance, here at the occipital cervical junction. And then we're not going to do a lot of mechanical approaches for this. So I think looking at the prednisone or looking at the biologic agents, we send a lot of these over to rheumatology. The only one I've seen was really bad. Dr. Trost had once where the pannus was so big it was pushing on the cord and you had to go in and decompress that. But usually that's not a surgical type of case that's going to happen. This is a tough one, the central pain. This would be a complex regional pain type of syndrome after a relatively minor injury. You can see the vascular changes on the right. There's hypersensitivity. I think these are the toughest cases on it. The key on this is you really want to get them into therapy and get them moving early. These lumbar sympathetic block can be helpful. The IV lidocaine infusions can be helpful, but a high percentage of these go on to have long-term pain issues. And so if you can start it early to recognize the vascular changes, the hypersensitivity issues, you'll get a better result. So Dr. Serta was talking earlier about a special test that we can do. I'm a big fan of the McKinsey Extension Program. McKinsey was a physical therapist in New Zealand. And when I was in physical therapy school in 72, 74, I was taught, no, you never do extension because what you're going to do, you're going to push the disc material posteriorly and pinch the nerves, and it's not good. So McKinsey's in New Zealand where a lot of his clientele is sheep shearers. So a sheep shearer is leaning forward all day long. and his back lasts about 7 or 8 years, and that's about all they can do it. So one day he was at work, and a patient came in, terrible agony. He couldn't even straighten up, and so he said, "Well, go in and lay on the plinth a little bit. I'll be in the treatment table. I'll come in and check you out in a little bit, and we'll see what we can do." Well, the table was up, so the guy laid on his stomach, and it was about 15 minutes before he got there, and he says, "Oh my God, the guy's going to be terrible because he's on his stomach all this time with his back arched. It's not going to work out." The guy got up and said, "God, I feel great. Thanks," and walked out the door. So what he said, it changed the mindset, and I think that was the key. We were so flexion oriented in the 60s and 70s in physical therapy that it made him go the different direction, and actually it turned out to be quite good. So the McKinsey approach that I like to use a lot, and I went to his course years ago, and fabulous lecturer. And the nice thing about it, it puts emphasis on the patient. Have them get their book, Treat Your Own Back, and just really work through the approaches on it. So that's just another tool. You want to have as many tools in the toolbox as you can, and I have found over the years that one has been quite effective. But whatever I do, I always send people out the door with 4 things I want them to do. I got to give them something to get to sleep at night. If they don't get a good night's sleep, they're not going to do well. So something mild at bedtime, because if you don't get the deep sleep, it's not restorative. You'll never feel better. The aerobic exercises we talked about. The specific spinal exercises, I never give them more than 5 because they won't do them, all right? The more complicated it is, the more likely it's going to end up in the top drawer and they're never going to follow up on it. And then try to teach them a little bit about appropriate activity modification, especially when it's a mechanical basis to the pain. So after the physical therapy, I went to DO school, and then someone said, "Well, better get a certification of something." So I ended up here, and it was a great residency. And then a guy named Tom Dept came along and said, "Let's start a spine clinic." And here's a letter he gave me in March of '89. He said, "The purpose of the Spine Center is to concentrate and coordinate expertise in order to provide comprehensive care to all patients with spinal problems." And that was one of the first ones in the country, I believe, around '89. And so it was a really good experience. The administrator of the hospital was really budget sensitive, so they cleaned out an old hairdresser's shop in the clinic next to sports medicine, and so we had a few rooms there until we built a new building in '95, which is over in Research Park. But I liked the philosophy that Tom came in with. He was dedicated to build a full program, very comprehensive program, and it went well, and the growth was quite good. Well, like when Greg and Cliff and Dan came along, and the nice thing about it was that Manuka Javid, I'm saying that right, I hope, and Andy and Beth, who were the chairs at that time, were smart enough to stay out of the way and let them work it out and build the program. And I think as it speaks well to our institution, the cooperation between orthopedics and neurosurgery was the key why this program has continued to grow as well as it has. And very open to allowing the advanced practice providers to grow as they did. So in March of 1990, the most important thing was Pretty Woman came out as a film, and now I can recite the lines before they even say them. I've watched it so many times. But along with that, we continue to grow the spine clinic. One thing is we tried to standardize things, and the pain diagrams at that time were one of the first groups that that sounds like a real basic thing, but you got to remember where we're at with this. The pain diagrams were started to be used along with our standardized questionnaire. And studies have shown the more specific the patient is and how they fill out their pain diagram, the better your chances of success are with treatment. So I put a lot of stock in that, along with their other history, but I really emphasize, and I try to talk to them about if they can, how discreetly they can describe their pain going down the arm or the leg, and it makes a big difference to help us localize before we get the studies as far as where we are. Another thing that happened during my career was in 1975, CAT scans came out, and that was best thing since sliced bread at that point in time. The only issue was when it first came out, the myelograms were done with lipid-soluble, not water-soluble solutions. So I think it was about approximately 1 to 2% of individuals got arachnoiditis from the lipid-soluble solutions. And for entertainment, I would go over and watch the radiologist do the myelogram and then suck the fluid out. And usually they pulled up a nerve and the patient kind of cried out in pain. So it was a very painful experience for many patients, and a lot of them ended up with the post-myelogram headaches. This gold standard for probably 5 to 10 years was the myelogram followed by the CT scan. To look for, especially looking at structural issues, look at the solidity of a fusion or any non-union or things like that. It was really quite helpful. So that held the crown for the best test until about then water-soluble dye came about, which also helped with the studies. But that was about mid-1970s also. Matrizumide was the name of it. And that is when we were able to start doing nerve blocks, epidural injections with contrast to verify the correct position. So realistically, we think, we've had these things a long time, but epidural injections, transfemoral ones, were not really common until probably in the 1990s when they really blossomed quite a bit. What did we do before that? We really weren't doing the spinal injection. So it's interesting how quickly that went along. So just as a good example of here, what a complete block would look like on a MRI study with no fluid passing below that. And the nice thing about on the myelogram, you can see the nerve sheath coming out. And I show that to residents just to give them an example of how you have to be careful, because you can get a spinal headache just going in through the frame, and if you're going too close, given where that is. The other one that was an interesting study in the past was epidural spinal venograms. These were done about the mid-1970s, just when CT scans came out. And like, for instance, in this case where we're seeing on the left side, we're seeing the blockage of flow of the contrast in the intrathecal pattern. I've seen on the right side, I've seen a venogram where there was totally engorged vessels all the way up into the thoracic spine in the venous plexus and nothing below. So it brought home to me how much pressure there can be in the spine blocking that flow. And obviously when MRI came out, it wasn't done anymore, but actually was a very valuable test to look for that as far as a blockage with pressure. An interesting study. Two of the strongest advocates of chymopapine were Dr. Mudhakar Javid and Dr. Gene Nordby here in Madison. And actually, they wrote some of the early articles on that. The whole idea was you take chymopapine, or Adolph's meat tenderizer, as is known, inject it into the disc, and it will dissolve that disc. And essentially, with a disc problem, you can have injury, inflammation, repair, and so it just speeds up that degenerative type of process. I found that when I was in Iowa, a neurosurgeon named Eugene Hertzberger, who was quite a fellow, was doing a ton of those. And we found that when the patients had that, the disc would collapse rather readily, and they would have tremendous muscle spasm for about a week after the procedure. But then with more of a centralized back pain or mild radicular pain, they would do awesome. So it was an interesting thing. I talked to Dr. Trost, was trained in it. I don't think he quit doing it. I think there were some issues. About 1% of people had allergic reactions to it, and they weren't tested properly. So there were lawsuits because of people dying or anaphylactic issues or paralysis because of it. But Dr. Nordby and Javid did have they had the patent on it. They were trying to get it going again, but they never went along with it. So Javid died. He was 101 about 2 years ago. And then Nordby is 105, died last year. So obviously working with chymopapine makes you live longer. So, and then in the 90s, probably in the 2000s, Dr. Segal, Nalini Segal, an excellent physician that works with us, was doing a lot of epidurograms, or I'm sorry, discograms. And where it's an interesting study, they broke them down to classification regarding how much of a tear there was in the wall of the disc, and was there reproduction of the pain at the time it was done. Actually, the reproduction of the pain was probably more of an issue. Fortunately, they found out that doing that speeded up the degeneration of the disc. And so it's no longer done anymore. But it was a valuable test, but it just wasn't, the risk wasn't worth it. So that is not being done anymore. I'm waiting for someone to come back with chymopapine. If they were screened properly, Javid always said all these people weren't screened properly. That's why they have the problem. So you surgeons think about that. It has a place, or interventional pain, think about it. It has its place. But there were other things also. Remember, percutaneous discectomy was done, whereby they put a little rotor-rooter in the middle of the disc and ream it out. Dept, where they put electrical, interdiscal electrothermal, where they put a needle in the disc to try to speed up the degenerative process. None of those worked out that well, so they all went by the bypass. And that's what Michael Sewer was talking about this morning. Every week there's a new technique that comes up on that. I live by the degenerative cascade that Kirkcaldy-Willis described. He's an orthopedic surgeon in Saskatoon, Saskatchewan. I suppose in the winter there's not a lot to do up there, so you think about why the disc is degenerating. But at any rate, this really is good because he takes it from the early degenerative changes down through the instability resulting in herniations and lateral tears of the annulus fibrosis, till you get the degenerative stage where you get the scar tissue forming, ligament flavum hypertrophy, facet hypertrophy, and then the stenosis and perhaps some spondylolisthesis with that. What I try to figure out is where are the patients at in this process when I see them, and are they stable or are they going to be unstable based on that? It's a good thing for other residents to be really comfortable with. And then just looking at the different disc abnormalities. What's hard to do is correlating, as you were mentioned earlier, the abnormalities on the disc with what the patient's symptoms are. A lot of times it just does not correlate at all. I get a lot of mileage out of describing the disc as a bellow, telling the patients, look, you got to move that to push that fluid in and out because it's such a passive environment. And as we age, the circulation coming into the disc doesn't go as well because the cartilaginous end plate will have a Schmorl's node. You've lost the pressure gradient along that. And so that is just kind of a soup waiting to deteriorate and solidify. So as mentioned earlier, I won't spend time on this, but in the low back, we were talking about looking at the joint above or below, and the low back we're always about, I think about 15% of the time it's going to be sacroiliac and or piriformis. It could be either one of them. Yes, you can inject it, see if it brings on the relief. It's still a bit of an art to do that. This is about a 60-year-old male that was sent with diagnosis of spinal stenosis. He was a conductor on the railroad for 40 years. He jumped off on the left side all the time. Well, he got a big divot in his hip, and he had no hip motion whatsoever. So we did the Faber test to check that out. So he just needed a new hip, and that actually, in that case, it was a hit. That was all we had to do. Back in the 80s and the early 90s, the Quebec task force really tried to put some standardization on the spine as far as what works and what does not work. The only thing that really had a good result was aerobic exercise. Everything else may or may not give short-term benefit, and some things were giving no benefit. But they had a nice graph that there was, I think, the first group that really came out with a nice study on this, and it's withstood the test of time. Some big names were in on this. Udeo's the big public health physician from Seattle that's always in on these. But the Saul brothers, who were big on Dept when that was out, also were good, solid physiatrists. And they said, look, what you got to do, you got to go through the sequence. If you're going to do rehab, once you get the pain under control, you get the motion back as much as you can. Sometimes you don't want to get too much motion back because the stiffness may be a protective aspect for the back. You got to get the strength up and the endurance, and it takes forever to get the endurance back. People think it's going to happen right away. Some will get the neuromuscular coordination back. Some will get back to their sport or other activities. Some will not. But this is with neurological disorders, this is how we would progress individuals along, such as with the stroke, and with orthopedic type disorders, it would be the same way. The last thing you're going to get back with a bad ankle sprain, you may never get that coordination back. And getting into the functional abilities is the most important goal of all. So 2005, Mariah Carey, #1 with her hit. But about the same time, there was a big emphasis on pain management programs, work hardening. And essentially, we're trying to recreate the person's job, to recreate their activity and rehab them. But they kind of went the wayside because really the best activity is the activity itself. So we just have to grade it as far as how people would progress on it. The ergonomics is still here, and that to change the way something is done, as Bill Ingeber, the hand surgeon, says, if you're getting carpal tunnel from the repetitive activity, don't do it. You got to get away from it. So you got to change things along that way. The ergonomics and job modification, there's 2 physical therapists here that are almost full-time do that type of work. I get a lot of good out of functional capacity evaluations. It gives a little more objectivity. If someone says they're going for disability or have a legal issue, I just say, look, let's get the test. It'll determine what your lifting limit is, what your ability to sit, stand, or walk is, what your ability to work a certain number of hours are. Otherwise, it's a scientific wild-ass guess regarding saying what someone's ability is to work. Then you compare that to their job and see if there's a mix. So we talked about looking at the joint above and below. These are what I check out. We talked about sacroiliac and piriformis. It's not infrequent, about once every 3 months, someone will come in and it's pain in the hamstring. It turns out to be an ischial bursitis. You inject it, and if it's better, it's going to be that. We see a ton of greater trochanteric bursts that are mistaken for an L5 dermatome going over the side. The leg length's an interesting thing. If I have someone stand and I look at their pelvic brim height, if it's off on one side or the other, then I have them lay down. I'll measure from the medium malleolus up to the most prominent point up to the anterior superior iliac spine. If it's about a centimeter, half centimeter difference, I'll get them a heel lift, usually correct about half of that distance. And because what happens, you come down hard on the short leg side. So correcting that, half the time it doesn't do anything, half the time it makes a big difference. Cervical, this is talked about quite a bit. I won't touch on this. So the only point I would make is we see a lot of Scheuermann's kyphosis or just thoracic kyphosis. And that's the problem, really. They're trying to keep their eyeballs level, so they're arching their neck more because of the kyphosis. We see a large number of women that have the pendulous breasts that are pulling them forward. And so we send them to plastic surgery for a reduction. But we have to say it's for functional issues, not for cosmetic reasons. Otherwise, insurance won't cover it. So Dale came out with this in the 2000s. He said, what's our role? Our role is we got to rule out neurological deficit and the need for surgery. Looking for systemic disease, and especially the inflammatory type disorders or neuropathy is a big issue. I look for the complicating factors. The toughest complicating factors is the psychosocial issues that come along. Dr. Janice Singles, an excellent pain psychologist here, says, look, when you first see the patient, you have the most influence with them. Every other visit after that, your influence decreases. So it's important, I think that Dr. Williams made a good point on that. It's important that early on you state what your role would be, what you have to offer, and what the time frame would be. Otherwise, it becomes a social visit as they keep coming back. So I think the important point to remember, so that first visit, really be clear to the patient what you can do and what their role is also, and set the expectations for them so they're not passively relying on you to do it. Why does losing weight matter? I get a lot of mileage out of this. If there's 7 miles of blood vessel in every pound of fat, I tell someone, look, you lose 10 pounds, your heart doesn't have to pump blood cell from here to Lake Michigan. And then 4 extra pounds, for every extra pounds of fat, you have 4 extra pounds of compression. So something concrete like that sticks with the patient and can motivate them. What we'd like to do is wish we had a body scanner where it could actually show the amount of fat around certain areas. I think that would be a great thing to use to motivate individuals. These GLP-1s, now I'm sending about probably 1 to 3 a week for their primary care physician to get their weight down with the GLP-1s. Most tolerate it well. A minority do have problems, but most tolerate it well. So as we're seeing our retirement funds go out the door today. We're looking at value-based healthcare. Where's it going? Where do we go from here? This actually was North American Spine Society. And I imagine, Dan, when you were chair of North American Spine Society, you were in on these talks also about what's valuable. The thing caught my eye was Michael Porter. He wrote some very nice books on competitive advantage and competitive strategy. But, you know, we do all these injections. They're expensive. If you start doing 2 or 3 injections, you're talking the price of a surgery. So is it really worth it to get up to about a year's relief, or is it better to go for a more definitive type approach? These questions are going to come up more and more. So they have their 6 basic concepts of healthcare, and these are also in other industries, but they transpose them to healthcare. So I won't go through these, but we're going to hear more and more about that. What's the value we have to offer of all the services, whether it's therapy, whether it's surgery, whether it's injections. So we've seen a tremendous increase, geometric increase in the number of stimulators, dorsal ganglion stimulators that are being placed these days. Are they good for the long haul? Some of the literature says they're 50% work great for 2 years, and then 50% of them don't work after that. It depends on whose statistics you want to read. But we're going to see more of these. Is it the best approach or not? These are the individuals, the ones that have had surgery or have an arachnoiditis. Those seem to be the ones that I've seen respond best to it. Someone with just axial pain, that does not work. So communication is clearly the case as we go through specialty care redesign right now, and I appreciate the efforts of Dr. Williams and Brooks doing that. Talking amongst the group is a huge issue. Telemed video visits, I found these less than fulfilling, but they seem to have a place. The ones that are really using it a lot are the psychologists, and that is the one that's probably growing more than anyone else. So the pain psychologists are able to reach out, especially for patients I see in the outreach clinic, it's good. Why are we not charging for my charge and phone calls? That's a question I'll leave to the group. So what's the trends? We got an exponential increase in APPs. I was on the credentials committee for 20 years, and when I started, there was about 50 to 75 physician assistants and nurse practitioners. I think we're probably around 500, if not more than that now. I think that's great. I'm happy to see that, and they're a valuable part of our group. The physical therapists are going to do more direct access, and we just need to include them in so that we know what the limits as far as what their role should be in that. And patients are going to continue to demand more, and how do we handle that? And who's the best one to handle cases that are just a chronic disease? Are they supposed to be in the spine clinic? Are they supposed to be in primary care? That's an issue our system hasn't addressed. An inpatient basis for decades, how you would solve a problem was transfer to another unit. But you can't, at some point in time, we have to look as far as what's the best home for these type of cases to be in. The other thing is, I talked to Dr. Brooks one day, what's more effective, surgery versus non-surgical approaches? To look at the economics of that, I don't think it's ever been looked at. I think that would be fascinating to see. Biopsychosocial model, it's going to be hard to quantify with artificial intelligence, but it's going to be here. I think it will have a place for us as far as diagnostic acumen, so we'll see what's up. So this is a wonderful environment, especially for teaching, especially to look at our team approach on it. And I've been very pleased with that. And where it's going to go in the redesign or how we can make it more efficient, we will have the effort of all to do so. And I will pass on that, and I thank you very much. Thank you, sir. Thank you very much. You bet.
We got a little more time left, and our next change we're going to do is our worst complications. I think we'll start with Dr. Tribune. I know this is, it's difficult for physicians, surgeons to talk about their complications because it's, you gotta kind of relive it sometimes, and that's very hard. But I do think there's a lot of value for people who haven't made those mistakes yet to see what kind of things you can do to somebody. And also, I think it's a very important part of our growth and development of our quality over time to realize that nothing is as simple as we thought. It's truly the littlest things can have a huge impact on patients and families, and so we have to be very cautious.
Thanks, Sam. It's not so hard for me to talk about complications. It's hard to pick out one out of a collection of 31 years. Yeah, it's actually, we all get a collection of these patients become very familiar to us. It's seasonal, so I'll share the story with you. Probably 12 years ago or so, I came walking in my clinic and looked at my sheet, which I would have occasion to do, just kind of see what the day was going to bring me. And I'm looking down, reading, it's about 18 patients on the list, and read the first two, and I go, oh, man. And I kind of read the next one, I go, oh my God. And top to bottom, it was my greatest hits of all time challenges. And I'm just beat up. I was tired by 9:05, and my Ellen Heiser was my nurse at the time. She looks at me and goes, April Fools. I actually printed out the entire form. So anyway, so you say you want to be a deformity surgeon, said no one ever. So I have given talks like this before, and I have a myriad of people I think about to present, and neurologic losses, deaths, et cetera. This is neither of those. It's just a challenge. And how resilient are you as a surgeon? And hidden in that is surgeon fatigue. And we have patients that will actually wear you out. And that is really tough because you are responsible to them, and they're still showing up, which is an incredible tribute. And I take it that I'm like, okay, this person's still sticking with me. Why? Well, they're struggling. So the patient's going to keep bouncing back, and you've got to communicate and get people through these things. And this case, I think, is a poster child of that. I did put all the dates on this, not to show how old I am, but to show you kind of the time frame of how this all went down. When I first met her, she was 27 years old. This is not a subtle deformity. And I took her to the operating for that in early of 2008. And I will tell you, I was struck by, this is not to show off how straight the spine got. I actually was a little worried about it, even at that stage in my career. I started thinking about Ehlers-Danlos and Marfan's and other things when curves were kind of hyper flexible. Adult deformity is usually not that flexible. So this kind of did resonate with me in the early period. And you can see anteriorly, there's a kick-out screw at 4-5. And that was because I started anteriorly because I really wanted to rebalance that 4-5 lateral ascesis. And it was so hypermobile, I almost never put a screw at 4-5, but I put one there just to lock that in. 6 weeks post-op, we're told already, look at what's happening at 4-5 level. Despite that screw being in there, it shifted forward about a quarter inch or so. But she was not doing that badly at that point. So I actually, and the hardware itself did not look like it shifted. It just looked like it spun around that screw. So I did sit on that one. So that was March of 08. Now here we are in what you think is kind of where we should be doing pretty well. She's about 6 months post-op, but she came in hurting further. I reduced the number of slides here, so I'm cutting to the chase. She had developed a pathologic fracture, or I consider it a pathologic fracture because it looks to me like it's related to that screw, right at the inferior aspect of the construct. No listhesis as of yet, and I sat on that one. So now we've got two going, and I'm getting out to November, so I'm 9 months out thinking I dodged a bullet with that one, and she's doing okay, and that's the film on the right. So 1 year post-op, she comes in and actually things had settled. Life had restored for her a bit. I went back and looked at this film with what subsequently happened. You can look at that 4 or 5 disc. I don't know what to term it. Maybe it's developing a spondy. Maybe it's just straining a little bit under the stress of the construct. But foretelling, now we're into 09, April of 09. And she shows up in our ER with a full-out cauda equina from that presumed degenerative spondy, but given that pathologic fracture, I don't really know. I hadn't re-CT'd her, but I was certainly going to address this. And we took her to the OR that night and did this construct as a salvage. So we extended her, and now she's post-op, and cauda equina actually responded fairly nicely, and we're backtracking again. So 4 months later, this. So a second pathologic fracture at the end of the contract. So at this point now, I'm doing metabolic workups on her. This is weird. OFER across the board. Sent her to rheumatology, sent her over to Nate Rudin in rehab. It was an incredible resource for Ola Stanlos in our institution. And I'm still coming out nothing. I'm trying to think outside the box a little bit with her, but I still have this clear mechanical failure, and that led to this. So now she's in the course of 18 months, been extended now down to fusion, which to those of you who know me, this is really painful. I like saving levels, but this was just driving the bus, and I was a somewhat unwilling passenger, but had to keep going. So things start spreading out a little bit. She settles down. She's losing some weight. She is healed, everything you can see in the CT scan through the lumbar spine. She really does not like the hardware. And this is where I started. Probably, maybe shouldn't have listened, because I ultimately did take that hardware out. And she was actually pleased with it until, let's see, 6 months later? 6 months later, comes back with increasing mid-back pain. And this is pretty much a classic because you have to think about where points of weakness are. When you're embarking on a fusion, we know the hardest area to fuse if you're going to the pelvis is that 5-1 level. So we hedge our bets by doing front backs and iliac fixation, et cetera. And then the next one's that top level. You don't think about the average levels too much in the middle, but whenever you've done an anterior fusion, your next level up, say you've done a 4-1, your 3-4 level's going to be vulnerable to a pseudo. So in this case, we had a really stiff rib, moment arm from T12 all the way down, just took this hardware out, and now I've got an open disc and a healthy disc, unfortunately, at 11-12, so she gets a fracture right through that fusion mass. And that necessitates what she doesn't want is the hardware going back in. It salvages it. I actually did it with a T-lift repair because that disc was pretty angry, and I could see where she might want this hardware back out again. So I was trying to be aggressively protective of the next discussion. And this is where I made a big error. Here's her fusion. She's solid. She wants her hardware back out. Take the hardware back out. Now we're 8 years post her fusion. She breaks through the T-lift, through the fusion. So she now has this. 6 weeks status post that repair. And that is my birthday, which was time to stop with this. So that hardware stayed in, and I did drive it deeply into the bone, but I was kind of done with the idea of taking hardware out. So that's the good news here is I've had 6 or 7 more birthdays since this, and she has not resurfaced with the problem. So what I learned, this person came back every time with their spouse, and she just wanted a normal life, and this is not normal. That's 7 operations. It's relentless. Listen to them because they showed up. You start blowing these people off, and in deformity in particular, Than does some, I do some. I think Jim's doing a little bit, but boy, they don't have a ton of places to go. They certainly can't go running back to their primary, and if you're not giving them your full attention, you're missing the boat. support them. If you clarify to them, I was torn between this case and another case that almost defined my career, of a person who I'd taken her hardware out, big scoli, and it was probably the third, fourth time I was in there, and it looked rock solid. And went around on her 2 days. 2 days later, she tells me, didn't get it. I'm like, oh, wait, watch, wait. I just saw it. I can't do it. I can't do anything right now. And I waited 6 months on her. She very persistently said this. And I said, okay, CT scan. Fascinating. You take hardware out, all the stress shielding goes away. The fusion mass was just a sheet of bone right to one level, which was an obvious pseudo, sheet of bone the rest of the way. She was right, no question. And if I had ignored it, I'd have missed a real opportunity to help her. And treat them comprehensively. You know, this person was going off the rails. I never got an answer for her, but I do think she knew I was listening because I found her situation so unique. So try not to be stupid. Yeah, taking that hardware out the second time was flat out stupid. Anyway, there I have revealed myself. Well enough long not to be stupid, but that was probably 15 years in. Yeah, I said the first surgery was
2008. Yeah.
Yeah, about 15 years.
Yeah. Okay. Yeah. So, I mean, I think these things happen all throughout your career, but they happen a lot when you first start because you don't really know exactly what things to do to people. You don't know as well as you thought you did, and especially in big operations, deformity operations, things like that. You just have to be really careful about your indications. You know, I know you've thought about this case a lot because you've dealt with it a lot over the years, but you know, seeing how much she reduced in the beginning, would you have maybe extended it down just at that point?
You know, that's a great question, Dan. As I think about this sort of a symposium, there's you have disasters like this, and all of a sudden the world becomes an anecdotal melting pot.
Yeah.
So the answer to that quickly is no, I would not.
Yeah.
Because there's a philosophy here that you live by a little bit, and if you start doing one-offs, you're going to overtreat people. And in fact, discussions lead to overtreating people. Talking to patients, say, okay, listen to you, I'm going to give you this option, I'm going to give you that option. This option is a little smaller, that option's a little more comprehensive. Why don't you decide? I can't stand that. It's my job to say, you know something, there's errors in spine surgery. I can overtreat you or I can undertreat you. I'm going to choose to undertreat you. We're going to know if you fail really quickly. Because if I overtreat you, I'm exposing you to more risk. And, you know, you got to decide where you're going to fall in that equation. But that to me is a really big one. That's fine.
Yeah, I think so. You know, it's telling the patients that you can always do more, but you can't undo what you did, I think is important. And as long as you can keep them safe in the midst of that, I think it's important too. So thank you very much. Appreciate it. Thanks for your time. Dr. Pride, here we go. So Dr. Kath Pride, thank you very much for coming. He's an anesthesiologist who works on the pain service. This is it's a good point that I don't know exactly what he's going to show, but of course, Cliff shows these horrific big hardware cases, and you can have a really bad complication in interventional pain, right? I presume. Yes. Maybe it's a good complication, but you can have really bad complications giving the wrong medication to somebody. So you really have to be careful all throughout the care that you provide. And what Cliff brings up is that you really have to stay with the patients as they need you, right? I think that one of the things you'll see, the most common thing you'll see is if there's a complication and you start to withdraw from the patient, the lawsuit follows shortly thereafter because they just feel like they've become unmoored, they've gotten damaged, and then they don't have anybody and no other recourse to help them. So it's very important to not only from the standpoint of you're avoiding litigation, but more importantly, from keeping the patients feeling like they are getting the care that they need, is that you own the complication, you explain what happened, you try very hard to be open and honest and deal with it the best you can and deal with it as long as you can. So thanks. Thanks, Ken.
Can everybody hear me? Is this okay? Am I? Okay, good.
So, yeah.
Thanks for the introduction. Yeah, my name is Kath Pride. I'm an anesthesiologist working in the pain clinic here. I work pretty closely with Dr. Rudin, works with EVS, and also Dr. Sewer when I'm doing my injections. I don't have any disclosures today, and the title of my presentation is My Greatest Complication and How I Dealt with It. This is a tough topic to talk on, as you guys have all alluded to. I liken it to that question in a job interview. What's your greatest weakness? You have to be very delicate with how you answer this question, right? Because you're going to be judged on it. So I'm relatively young in my tenure and career, and so I really haven't encountered too many large complications. I think that every one of us will encounter some manner of complication, whether large or small. Hopefully you avoid the large ones because you see enough small ones early on in your career where you can use those as guidelines to stay away from. Or you go to enough symposiums like this and you say, I'm going to not do that. So in any case, I made my font here larger about how I dealt with it because I thought, honestly, that was the more important part. And again, such as Dr. Tabu and Brooks have alluded to, that is a very important part to it. So the background is actually a 61-year-old. I lied straight off the bat. Female. She has a history of a left L5 radiculopathy, lumbar spondylosis, and stenosis, and a long-standing history of low back pain. She also says some other comorbidities, which haven't necessarily been treated, including some scoliosis, kyphoscoliosis, as well as idiopathic polyneuropathy. When she came to me, she essentially had low back pain. That wasn't even her primary complaint. It was actually neck pain, which we dealt with. We moved on later to her back pain with a little bit of numbness across her left leg. It was worse with walking. She denied any frank weakness, but did report an extensive history of physical therapy, which she did not want to repeat or seek any more of. She did have a laminectomy at the left L5 level previously. This is about 6 or 7 years previously. But that was not the pain she was really presenting for. It was mainly this low back pain with some referred radiation to the left hip. So this is her past medical history. It was long and arduous. Some of the more notable things I highlighted in red there, which I mentioned before. If you see anything that I didn't highlight, maybe I'll go back to it. But it was, pretty extensive. Medications, I tried to, again, highlight the ones that I thought were important, specifically and importantly, no anticoagulants. Had tried a multitude of pain medications before she had gotten to me. We didn't really initiate or start any new ones with the exception of tinkering with some of her anticonvulsants like gabapentin. Surgeries, the laminectomy right there, some other non-contributory surgeries on the left, and then these also previous injections, both prior to and after her surgery, which she stated were not very effective for her or actually caused a worsening and exacerbation of her symptoms. So that was something I kept in mind too. One of them was a pretty significant exacerbation of the left leg pain after the transforaminal she received. So the series of events, about 6 months after I initially saw her, we got to the procedure room. That was by her timeline, not mine. We ended up doing a caudal epidural steroid injection for multiple reasons. Her pathology of her spine, her previous surgery. These were reasons that I opted for a caudal initially. The procedure went as planned. I believe I had assistants in there, a resident or fellow, but we easily accessed the space. It was what I thought to be a normal and acceptable contrast spread. We had some pain on injection, but there's almost always pain on injection. When you inject the epidural space, depending on the age of the patient and the MRI findings, you really have to be cognizant of how much pain and where you're causing this pain, because you want to know, are you in the right spot, but are you in the wrong spot, especially if you're approaching transforaminally. Things to keep in mind, a subdural injection where you're in a very small, harder to get into potential space that can cause some big problems. And then also you don't want to be intravascular, so you're paying attention to the contrast spread. This is not my image. This is just an image of a caudal approach. So I'm going to say post-op day, post-procedure day 5, she contacted her clinic and reports that the evening of the procedure, she had a reduced feeling in her left appendage, the knee, the foot, the calf. It felt kind of floppy at that time, but there were no falls. She had a really bad increased pain in her back. At baseline, I believe it was like a 5 to 6, so this was worse. And again, pain in that left lower extremity. She also had pain in her right lower extremity, but not nearly to the same extent. No bowel or bladder symptoms, no saddle numbness, and the right leg. As it says there, some foot pain, but no numbness. And many of these symptoms were not present prior to the injection, and so she was instructed to go to the ED at that point. This was, I think, received by my nurse and the nurse practitioner, so I didn't even get eyes on this at that point. Not that I would have said much different, depending on the time of day. This happened to be like on a Friday in the afternoon at 3:45 or something. And so it was to get her care, we suggested you go to the ED because nobody's going to be in clinic by the time you get here. Okay, post-op day 7, she had followed up with what she described as an orthopedic surgeon, which ended up being a rehab physician. She did not go to the ED. She did report to him some fecal incontinence times 1 to 2 episodes, but to confound things, she had had that sometime in the past, once or twice. And her first episode of this was on post-op day 5. She also reported some intermittent urinary incontinence. Neither of these were really present prior to or at that first phone visit that she phoned in. So that physician suggested she get an MRI quite quickly. So skip. She didn't really get the MRI too quick. We are now on post-op day 17. Fortunately, this is what the MRI showed. Not a lot of great significance. You see I bolded there some unchanged moderate left neural foraminal narrowing. It was actually mild, I think, in the MRI prior to this, but again, that's at the left L5 side, left L5 level. And then what you see there, some degenerative disc disease and some modic type 1 degenerative end plate changes. Nothing really to explain what her presentation is today. So to me, that was reassuring because this is when I actually kind of started taking note and paying attention to this patient. So I saw this. I called her the next day or whenever I was next in clinic, and we talked about her symptoms. We talked about the results of the MRI. I tried to provide some reassurance, but obviously she was still in a lot of pain. At that time, she described weakness. She was having a lot of difficulty flexing and moving that leg on the left side. Also some numbness. She couldn't really sense her foot on the ground. This resulted in a pretty unsteady gait that ended up lasting quite a long time. And then this, again, ongoing numbness. Essentially, this pain was very similar to what it was prior to injection, only much, much more severe at this point. And then obviously the associated weakness and numbness too, which were not there. So the assessment, essentially the MRI greatly unchanged, didn't really explain a lot of what we were seeing. Initially, there was obviously a concern for something more sinister, like an epidural hematoma. I was racking my brain as to saying what happened, what did I do wrong, what could I have done better, what do I need to do now? I tried to rule out, obviously, all the things that needed to be addressed immediately. I did not think there was a need for surgical intervention at this time because there was really an absence of significant abnormalities or targets or hematomas that could be targeted surgically. So my initial management at that point was I talked to her on a Friday. She didn't want to come in at that point. So I said, I need to see you eventually, soon. I'd like to see you today. She didn't want to. So she eventually came in, I think, the following Monday. And that's the first time I saw her in person. That Friday, I had initiated pain management. Essentially, I wanted her to be as happy as she could, as well as reassurance. So we titrated some hydrocodone at that point. We started a measurable dose bath. She had a poor response to Lyrica in the past, which is why she was on gabapentin. We optimized further gabapentin. And then I followed her up very closely and in person. How I dealt with it, what I basically just said, I tried to stay in close contact with her as these things developed and unfolded. I have made myself very contactable and obtainable by phone or by my chart. I tried to answer her questions promptly. I provided the reassurance for when and what I could. I tried to be honest and remain hopeful for her. I researched what I could when I could on what she had and how she presented, and I tried to enlist the help of other physicians that I had, both in my clinic and in others. So possible caudal epidural complications. I know I'm on a time limit here, but I'll try and be brief. Infection, a longer standing one. Bleeding or hematoma, nerve damage, spinal headache, temporary loss of bladder and bowel control. Other differential diagnoses, I'm considering obviously the subdural injection, some sort of allergic response, malingering, arachnoiditis, none of which I'd seen a lot of. Again, I'm a relatively younger practitioner, so I'm reading a lot about these things and make sure I'm ruling them out. Continued care, she had very slow but gradual improvement in all of those rubrics, pain, sensation, and strength. Significant in her right side, less so on her left. She didn't have any incontinence. I think after the first couple weeks, the pain remained. Ongoing management, we did some opioid rotation and optimization there. We maximized the gabapentin, added a muscle relaxant, initiated some therapies, physical, occupational. We encouraged whatever movement we could, initiated pain psychology, and then still continued weekly to bi-weekly follow-ups. We got an EMG sometime in the second month to ascertain what this true weakness was, or if it was a weakness and what was going on. It showed a mixed axonal more than demyelinating polyneuropathy. She'd had a polyneuropathy previous to this, but it wasn't really diagnosed as to what for or why. They suggested it was secondary to previous heavy alcohol abuse, but the EMG showed no evidence of radiculopathy or myelopathy at that point in the left lower extremity. So my question at this point, why wasn't she getting better faster? Was there something I did? Should I be doing more? What is indicated, like a spinal cord stimulator or a dorsal root ganglion stimulator? Should I continue to escalate opioids? When's an intrathecal pump indicated? When is a repeat MRI necessary if there's no real significant change or frank worsening of her symptoms? So what am I thinking? Is this an exacerbation of polyneuropathy? Is it a worsening of a radiculopathy? The MG said there was no radiculopathy. Is this arachnoiditis, something I'd never seen? And what are other possible causes to these symptoms? Syringomyelia, not really. Cauda-Equina syndrome, usually more acute. Multiple sclerosis, again, a weird acute presentation, not usually like this. Spinal cord tumor, we would have seen most likely, and abscess and hematoma, we would have seen on imaging. So post-op 4 or 5 months out, we repeated a lumbar MRI. She slipped on the ice and she sustained a compression fracture of T12, among other things, and she just can't win. But also it showed some mild clumping and distortion of the nerve roots of the cauda equina, which may reflect arachnoiditis, which was my working diagnosis from then on out. So kind of a post exposure to the contrast arachnoiditis. This is just a picture of her tuberplasty, which is something I think she eventually went on for. Arachnoiditis is a chronic inflammatory condition of the arachnoid membrane. It covers the brain and spinal cord. Treatment options vary depending on how it presents. It can be classified into several different types based on its cause and location. Adhesive, cerebral, neoplastic, post-myelographic. These are not, again, her images. Her images were much less significant than this, but you can see on the same level pre and post. You have some freestanding nerve endings, nice and loose and singular, whereas here they start clumping. Signs and symptoms can be pretty broad, but chronic pain, some neurologic deficits, both of which she had, so hydrocephalus and arachnoid cysts, not applicable in her. Sexual dysfunction, we didn't really talk too much of, but she didn't really complain of, but there's the bowel and bladder loss of control there. Treatment for arachnoiditis is mainly supportive. A lot of the stuff that I did, so the PT, the OT, the pain psychology, managing her pain as best you can, getting anticonvulsants on board, or muscle relaxants as well, if indicated. And then collaborate with other healthcare professionals to see what they think. Early on, one of my colleagues suggested a spinal cord stimulator. I was a little gun shy. I think I didn't want to make things worse. Same goes for a repeat epidural or a repeat administration of a steroid. I don't know to what exposure caused this, whether the contrast or steroid local anesthetic. Money is probably on the contrast, but I may jump to a consideration of a spinal cord stimulator earlier on in the future for this patient, but it's definitely not cut and dry. And it's a a conversation I'd have to have with the patient, sit down, whether she trusts me again, that type of thing. Those are the medications I went over. There's PT and then surgery. I kept in mind surgical referral, but again, I didn't really see a target, and I don't think it's ever wasting their time. But I obviously go through in my head and think, what are they going to go through with a surgeon? What are they going to tell them? And something you should always keep in mind, especially if you see a target or a need, or even up to a curbside, one of your colleagues, if they have that available. So some other treatments, experimental stem cell therapy, TENS, kind of like dropping water droplets in the ocean, but by hook or by crook, whatever improvement you can gain is helpful for these patients. So I have found varying sources saying whether corticoids would be effective versus not, both injection wise and oral Medrol dose pack wise. So arachnoiditis not super well understood as far as prognosis. It's just a lot of supportive measures. So these are some prevention techniques for arachnoiditis. Don't get spinal procedures. Do what you can to prevent infections. Try to avoid intrathecal injections, things of that nature. So, questions, some that were answered, some that remain. Intrathecal therapy like pain pumps can be used, but that has also been shown to worsen this condition. Surgery remains unclear. I guess it depends on what causes the typical or your specific case of arachnoiditis. And then again, talking about epidural steroid injections, it's not generally recommended because of chemical spinal injections can exacerbate this particular condition. So, yeah,
Just a couple of questions. Thanks for the communication and presenting this.
Yeah.
So you mentioned on her past medical history that she had a history of Parkinson's Turner, brachial neuritis.
Yeah.
So I just wondered if she ever, saw like neurology or something like that to see if she was just like prone to developing some type of weird neuropathy or something like that, and for pathology, just be like some weird paraneoplastic thing.
Not that I know of, and something very much so to consider.
And a level sacral plexus MRI as well too, just because, if she had that Parsonage Turner syndrome, I don't know if she just has some weird predisposition to stuff like this.
Yeah, I had a slide in here originally of just like confounding factors that going back through her chart now, as just with a more, I guess, removed person saying like, these were just kind of weird things. Why is it like that? Why did she respond to that injection like this? And I had like 4 or 5 of them. I didn't include it, but that would definitely be included amongst those. So thanks for pointing it out.
Excellent. Yeah, so file this under the, there's no small thing we can't mess up.
Yeah, exactly.
Who's
But count me gun shy for every cuddle epidural I do now. So.
and that's one of our next speaker's favorite line is there's nothing we can't mess up, and so we have to be very careful about that. What? So it was my great pleasure to have Dr. Resnick here, and I appreciate him taking the time. I know he's looking forward to some birthday festivities, et cetera. Dr. Resnick has been a great mentor, and then later on a great partner. So I'm very, very happy to have him here. He's taught me a lot, and most of it's about complications and stuff. So this is a good topic for him. So thank you very much. Appreciate it.
Thanks, Dan. I'm going to just echo something that Cliff said. I remember every one of my complications. This is not my worst complication, but I thought it would probably be the one that's most relevant for this particular conference. But I can tell you that I can remember Igor. I put a screw through his canal my second month into practice. I can tell you about Vern, who I operated on, I think, 11 times over 20 years, who had every complication that Cliff just showed, plus a couple others. I remember Dale, who's the guy I almost killed with a hip graft harvest. He developed a necrotizing fasciitis, and then at one point, the general surgeons were recommending that we withdraw care. I was going to present him, but I'm actually seeing him in clinic next week, so I figured I'd get the full story. He's kind of pissed off at me, but we have a good relationship going forward. This is Goldie. So this is a woman who I knew me see if I can get the, I had previously operated on her before. She is a prominent person in the Jewish community in town. I'm part of the Jewish community in town, so everybody knows everybody. And you know, I'm basically for the Orthodox community, I'm the guy. For all the spines, so I'm the guy. So she's a relatively prominent lady. I had operated on her a couple of years ago for cervical myelopathy, and she did pretty well with that operation. She'd recently had a right hip arthroplasty about a year ago, and this was complicated by a sacral insufficiency fractures, urosepsis, and pneumonia. So her frailty index is about 1 million at this point. She's been in and out of the hospital for the last 6 months doing rehab. And 2 months ago, she developed the acute onset of severe pain radiating down the back of her left leg. She can't walk, not only just because of this pain, but also because of persistent issues with the hip. She uses a walker. She had a spine injection about a month ago, which helped, but wore off within a couple of days. She's on a relatively high dose of narcotics, and this is not a drug person. This is the opposite of a drug-seeking person. And the pain appeared to be roughly in the L5 distribution as she described it. Her examination, to summarize, other than a markedly positive straight leg raising test on the left side, her examination was normal in terms of strength and sensation in lower extremities. She had relatively hyporeflexic extremities, which was good because I'd done her ACDF, so I was glad she wasn't myelopathic anymore. but essentially a normal neurological examination, and the only finding I noted on my examination was the straight leg raising test. This was her MRI scan. So she obviously had multi-level lumbar stenosis. Alignment looks pretty good. She's got disc-based collapse for most levels. Here are some representative axial sections. The only reason I'm showing these two, all those levels looked narrow, but you can see that on L4-5, which is over here, she's got a disc herniation right here on the left side. So she's got stenosis. I'll go back up. Let's see if this can go reverse here. She's got stenosis with clumping of the nerve roots and such at 1, 2, 2, 3, 3, 4, 4, 5, and 5, 1. But the disc herniation appears to be at L4, 5. So, Young Von, what would you do with this lady? Seems to be L5-ish. Well, that might have been a smarter thing than what I did. These are her X-rays that were obtained just prior to her hip. They were trying to figure out the other side hip pain, and they were evaluating her spine at this point. So she got these X-rays at this point. A little bit of scoliosis, nothing really too remarkable. Other studies, I didn't do any other studies. So what's to do? Do you just do the discectomy at L4-5? Do you do a laminectomy and discectomy at 4-5? Do you do a multi-level decompression plus or minus the discectomy, multi-level decompression plus fusion, T10 to pelvis, or something else? And I fell into Cliff's trap where I gave the patient options. We can do something small, we can do something, and of course they always say, I just want to have it done with. So just do whatever you're going to do, I want to get this done with. But as Cliff alluded to, and Fan alluded to, more surgery doesn't necessarily mean a better outcome. More surgery just means you've had more surgery and your complications are going to be different than with the smaller surgery. So I did what I thought was sort of a middle level aggressive surgery, and I did a multi-level decompression from L1 to L5, and I did the discectomy. So I decompressed all those clump nerve roots. I did the discectomy on the right. There was some dural thinning, which we occasionally see from time to time, but there was no CSF leak. She had a somewhat prolonged hospital stay due to pain issues. I also was relatively slow to mobilize her because I was worried about a CSF leak. But she eventually went home on post-op day 4, and medically she did just fine. I saw her back at 6 weeks. The wound was healed well. There was no evidence of any spinal fluid issues, but she was still having 10 out of 10 pain in her leg. The back pain was not really an issue. She said the pain was a little bit different than it was pre-op, but it was still horrible pain. So the question is, what went wrong? Why didn't she get better? Any ideas? Sarah? Cliff? Yeah. Sometimes you do see they get worse for a little while and then it cools off again type thing. Exactly. Yeah, she's not spewing CSF, so I'm at least relieved about that. Yeah, Kelsey. That's maybe I did. So what would you do to investigate this? Right. So we got X-rays, and so here's her X-rays. You can see the new hip, and you can see the decompression here. And what? Anyone see the? I put the reading there, but is that still in the room? No. Yeah. Cliff, take a look at that left hip. Yeah, it's substantially, it's substantial. It turned out she had avascular necrosis of the hip, which really was the cause of her pain. So this was actually a hip X-ray she'd had prior to surgery, which wasn't as bad. So her acute pain was really due to avascular necrosis of the hip that I missed on my examination. I did a straight leg raising test, but I did no hip provocation maneuvers on this little lady because I was so sure that disc herniation was. So I went down the primrose path. I did not do an adequate examination in a clinic, and it came back to burn me. So she actually went and got a hip replacement and did fine. She actually still likes me. I still see her around. She's actually developed another problem that's unrelated to this that I'm working with her for. So this was just it shows the importance of a thorough preoperative examination. I don't know if the operation was completely unnecessary, but it certainly did not address the main problem that she was having, which was the avascular necrosis of the hip. And that's that. So thank you all very much for your attention.
I think that's obviously it's fair to say, even though we do surgery very carefully, exposing somebody to a great deal of risk when it's not the problem is a huge. You feel a lot worse for it later on in life, but you definitely know that you've put this person through the ringer. I've had at least one or two patients the morning of surgery cancel because I realized it was the hip, and so I've been happy that I've found that out and figured that out before I did anything to them that might hurt them or damage them. So that's been very helpful. But I really appreciate you guys coming and talking about that and doing some very open and honest discussion. Yes, go ahead. I guess it just depends on what you see when you're manipulating and kind of what kind of mechanical things you're doing that cause them to get the pain. Because people often will describe it as being more of a groin pain. But there are plenty of hip surgeons who will say they get back pain also. And of course, people just get weird referred pains that you just can't always account for. But I think if it's related to hip manipulation without the leg being straight, it may actually be hip joint pathology as a reasonable consideration. What do you do then? I typically will first get X-rays if you haven't gotten them. And if they don't show anything, sometimes inject that joint and see what happens there, rather than put them through a surgery first and then do all that afterwards. Yeah.
In my heart of heart, I think you probably needed both things done.
Yeah. That after the hip got done, he probably would have. The hip surgeon would have been like, "You need that."
Let's talk about Occam's razor, trying to narrow all complaints to one diagnosis, but there's always the Will Rogers corollary, is that a man can have as many diseases as he damn well pleases, and you can have often more than one thing going on at a time. So I suspect that she was going to need to have both done anyway, but it was disappointing. I was disappointed myself in terms of the sequence of events.
Yeah, I often tell patients in this age group they're like vintage cars, and they're going to probably need a lot of things done. Yeah. So
vintage. Yeah.
Okay. Well, everybody, we made it on time roughly. And so say thank you very much for coming. Remember, the lab is tomorrow. It starts at 8 a.m. for those of you who've registered. It's a great learning experience. Get a chance to see things done in the cadaver, get your hands on it if you're part of that crew. What I really want to point out and say is I really appreciate everybody from all the different services helping out with these patients, because I think that makes a huge difference in how we can take care of spine patients. It really helps us. For those of you who are going on to look for other jobs, make sure to try and recreate a miniature version of this, okay? Like you basically can't really effectively take care of spine patients if you're just doing surgery on them. So you have to figure that out. So thank you very much.